Good morning, everyone. And welcome, both those here at Matter and those joining us virtually, to the 2025 Loyola Health Equity Quest Innovations in Cardiovascular Health Summit, a program that Loyola University Chicago and Matter have proudly collaborated to host. This year's Health Equity Quest focuses on innovations in cardiovascular health, with a particular emphasis on wearable technologies, a topic at the forefront of advancing equitable care. I'm Mike McGarry, Senior Vice President of Venture Acceleration at Matter. Matter is a healthcare technology incubator and innovation hub built on the belief that collaboration between entrepreneurs and industry leaders drives the best healthcare solutions. Our mission is to accelerate the pace of change of healthcare, and we do that in three ways. First, we incubate startups. Since we launched 10 years ago, we've worked with more than 1,000 companies that range from very early to growth stage startups, and we have a suite of services to help at every stage of development. Second, we work with large organizations, such as health systems, associations, payers, and life sciences companies. To strengthen their innovation capacity, we help them find value in emerging technology solutions, unlock the full potential of their internal innovators, and create a more human-centered healthcare experience through system-level collaborations. And third, Matter is a nexus for those who are passionate about healthcare innovation. We bring people together to be inspired, to learn, and to connect with each other. This marks our fourth year collaborating with Loyola University Chicago on the Health Equity Quest. Past summits have tackled topics like sustainability, climate change, and workplace mental health. Today, we convene executives, entrepreneurs, investors, policymakers, and academic leaders to explore how innovation and cross-sector collaboration can improve cardiovascular outcomes and reduce health disparities. We're looking to promote learning and ignite collaboration among everyone here at Matter and those joining us virtually. Together, we aim to accelerate progress in advancing equitable cardiovascular health, leveraging innovation, wearable technologies, and shared expertise to close gaps in access and outcomes. Our hope is that you leave today energized to continue building partnerships that move us closer to a healthier, more equitable future. But before we begin today's discussions, I want to take a moment to acknowledge the many partners who helped make this summit possible. A big thank you to the Loyola team for their partnership and leadership, especially Dean Elaine Morato, Mike Bloom, Merle Thomas, and Ann Davida Kopaz from the Parkinson School of Health Sciences and Public Health. We also acknowledge the Marcella Niehoff School of Nursing, Parkinson School of Health Sciences and Public Health, and the Stritz School of Medicine for their collaboration. A special thanks to our external collaborators, the American Heart Association, the Healthcare Council of Chicago, and MHub, as well as our corporate sponsor, Alight Solutions, for their generous support. It's now my great pleasure to introduce Dr. Douglas W. Woods, Provost and Chief Academic Officer at Loyola University Chicago. Provost Woods.
Thank you, Mike, and welcome to all of you joining us both in person and virtually wherever the camera is. Oh, there we are, over there. For 2025 Loyola Chicago Health Equity Quest, Innovations in Cardiovascular Health. We're deeply grateful to Stephen Collins and the entire team at Matter for their partnership, not only for hosting us today, but for their ongoing collaboration in advancing health innovation and health equity. Cardiovascular disease remains the leading cause of death in the United States. It affects every community, but its burden falls disproportionately on underrepresented and underserved communities. Emerging technologies from wearable devices to AI-powered diagnostics are opening new possibilities for preventing, detecting, and managing heart disease earlier and more effectively. This work, blending learning with community engagement, helping others, is fundamental to our mission as a university at Loyola University Chicago. Specific in our mission statement, we talk about the purpose of our university is working to expand knowledge in the service of humanity. Very applied, making a difference in the lives of the people that are in our communities through learning, justice, and faith. This work is key to that mission. Throughout today's program, we'll explore how data, digital tools, and cross-sector collaboration can make heart health more accessible, proactive, and sustainable for all. At Loyola, we recognize that health is shaped by a complex interplay of systemic forces and by the immediate challenges to personal and communal well-being that people face each day. At the Parkinson School of Health Sciences and Public Health, and indeed throughout our university, we bring together entrepreneurial energy, broad-based expertise, and a fervent spirit to impact the determinants of health in all their dimensions, again, to pursue the improvement of humanity through learning, justice, and faith. We are preparing a new generation of diverse health leaders to be persons for others in the Jesuit tradition, dedicated to reshaping the conditions for healthier lives in every way for individuals, families, and communities. Producing this year's Health Equity Quest has been a true collaboration involving multiple partners across our university, including the Marcella Niehoff School of Nursing and Parkinson School of Health Sciences and Public Health, and the Stritch School of Medicine, from which our keynote speaker today, Dr. Kumar, is an alum. So welcome back. We also know that advancing health equity requires partnership beyond our own disciplines and institutions. That's why we are so pleased to be joined by external collaborators today, including the American Heart Association, the Healthcare Council of Chicago, and MHub. Please join me in acknowledging all our university and community partners whose commitment has made today possible. I would also like to extend special thanks to the Parkinson family for their generous support of our school, our Center for Health Innovation and Entrepreneurship, and today's Health Equity Quest. And we are most grateful to Alight Solutions for sponsoring this year's event. You'll be hearing from them shortly. Finally, it is my great pleasure to introduce the founding dean of the Parkinson School of Health Sciences and Public Health at Loyola University Chicago, Dr. Elaine Murato.
It is indeed my pleasure to be able to welcome you all here today, both those attending here in the room. There's energy in the room as well as energy I know online. I'm told that we have near 500 that have registered online, and that it represents people from all over the country. And this year we have the exciting opportunity of having viewing parties at our two campuses, one at the Health Science, where we have our more likely graduate students and those in the health disciplines, and then also at up the lake a bit at our Rogers Park area, and touching on students there and getting to be part of this conversation. So it really is wonderful to see such a varied audience. As we've heard from our prior speakers, that's really the goal here, is making these kinds of connections. Many universities convene, forums, have discussions like this. And sometimes we can be talking to ourselves. And I know there are other forums where industry talks, and then there's forums where health systems talk, right? And really what we're trying to do here in our quest together is be also questing together with one another and learning from each other, because that is the way that we can affect humanity with innovation, is by rolling up our sleeves together with one another. So it's really exciting to see the wide variety. So why health equity, and why I've just mentioned a quest? Well, this annual event has really become a pillar initiative for our school at Loyola Chicago. And that's because our expression in health of the Ignatian values is around health equity. And our anchor is language that comes from the World Health Organization. The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being. And so really it is our calling to make sure that technology, innovation, insights reaches all, so that we improve the light of all, so the health of all. And technology are tools, but it's through a humanistic lens of how do we bring technology to people and to practice and adoption and all of those good things, is how do we get the return on those promises. And so I'm just really excited with the leaders that we have here today and the panel discussions that will bring that to life. So this year's quest is focused on cardiovascular health, and I would be remiss as an epidemiologist and a public health without giving you a stat or two. Yes, it's the leading cause, and sometimes we say that, and it just goes in one ear and out the other. It's hard to really wrap your arm around what does that mean. It means that the concern is that if we think of 40% of our children right now in the United States are at unhealthy weight. and that obesity and unhealthy weight is a leading contributor of excess death. It translates to about, these are stats from the American Heart Association, about 1,300 excess deaths a day. All right, that's just from those that are associated with obesity. When you think of all of the factors that affect cardiovascular health, behaviors, smoking, activity, nutrition, sleep, clinical factors, cholesterol, blood pressure, glucose, et cetera, you can see these are all measurable. And these can all be measured with devices and wearable devices. And so how do we connect our ability to be looking at these factors so that we can be improving health outcomes? So it's not just a disease that we say, yes, it happens, but something that we can be activated on to address. So that's the focus of the quest, and it's a focus to bring young people alive with it, because it's affecting younger people more and more. And it's not just individuals, but when you're a young mother, it affects the birth, the healthy pregnancy, and therefore the life of the next generation. So it really is a multiplying effect to be focusing on this topic today. So very grateful for all that have convened, and I just want to extend also my gratitude to Stephen Collins and the Matter team. It enables us at a university to be connecting with many of you that we couldn't do just by ourselves. And particularly, I want to acknowledge the work of Olivia Phillips for her leadership in assisting us, and with much gratitude for the Parkinson family for their generous donation to enable us to have a Center for Health Innovation and Entrepreneurship. And as well as our colleagues, as Doug has mentioned, within the Loyola University Chicago, those within our sister schools of nursing and medicine, as well as our external partners of the American Heart Association, the Heart Care Council of Chicago, and MHub. I also want to introduce a special feature. For those here in the room, you might look behind you and you can see there's a board that's starting to visually represent what we're discussing today. We know about the power of visuals and storytelling, and so we're very honored to have Kelly Evanson here. Oh, excuse me, wrong name, my mistake. I looked at the wrong part of my page. We're very excited to have here someone that is helping us bring from Ink Factory, an artist, Anastasia Nesbeth, who will be transforming the ideas that we're hearing today into visuals that we hope carry on and help us continue the conversation when we leave. So back to my appropriate introduction to Kelly Evanson. She will be speaking next, and we're very much appreciative of the sponsorship of Alight for being our corporate sponsor here. Alight is a very important player if we think about health and social determinants of health. They're a leading cloud-based human capital technology and service provider for many of the world's largest organizations, which affect over 36 million people and dependents. I've been told that that accounts to about 1 in 7 Americans are receiving information about health benefits and about their financial health through the solutions that Alight provides. So when I put on my public health hat, I think, wow, how many opportunities is there to affect 1 in 7 Americans with health messaging? So we're just really delighted. It's through their administration of these employee benefits that they really, truly are affecting the social determinants of health, in how they are helping clients gain benefits, advantage with building a healthy and financially secure workforce, and unifying benefits across health, wealth, well-being, et cetera. Kelly is the Vice President for Technology Enablement. How appropriate to have her with us today for the focus of our session. She's responsible for leading cross-functional technology initiatives with an eye on value creation for their clients, and working across engineering, infrastructure, security, and end-user experience gives Kelly a unique customer-focused perspective on the challenge we face in translating innovation and technology to practice. Her work is supported by her deep understanding of the healthcare industry transformation and technology. So please join me in recognizing Alight Solutions and welcoming Kelly Evanson to offer her brief remarks and introduce our keynote speaker for today. Thank you.
Thank you so much for having me here on behalf of Alight. I've been with the company over 30 years. And in technology, you can imagine how much change has occurred in that space. When I started with the company, if you wanted to enroll in your medical plan, you would call our customer care and they would walk you through those plans. And then we had this crazy idea of, what if we put benefits enrollment on the internet? So in 1998, we had launched our first site before Amazon, before Google, before a lot of things. We even tested in Netscape. That really shows my age. And in those 30 years, I started in technology for 10. I spent another 10 serving clients and listening to the concerns of keeping a workforce healthy. It aids in productivity. It aids in stickiness, especially in deep knowledge-centered industries like aerospace or finance or medicine. Retaining that talent is really important, not just in a health fashion, but in the tenure of how does an employer make their experience unique and supportive for their employees. So thoughts on ubiquitous technology. I've only been here since 8:30, and my mind has been blown by talking to various people in the audience here in the room on the opportunities of measuring what is normal. How do we care for athletics? How do we look after animals? The myriad topics that I've been exposed to is just unbelievable. So I cannot wait to hear thoughts from our keynote speaker. He's published articles joining biology and technology, making life better for children, removing the fear from tests when it comes to glucose or cortisol or other things that can be invasive but can help with their care. He is a graduate, as mentioned before, of Loyola's Stritch School of Medicine. Without further ado, I would love to introduce our physician researcher guest on the health team at Apple, Dr. Rajiv Kumar.
My kids were born at Loyola. I love Loyola, and so just grateful for the opportunity to be here, and grateful to Matter as well, and to Alight. And so today I was asked to give a background and talk a little bit about wearables and how this all fits and how we come together as a community, how we think about technology, how we think about research, and where these pieces fit. And I was reflecting 10 years ago, the world looked very different from where I thought it would be in 2025. And in reality, it doesn't look that different 10 years later. The clip is changing, the pace of change is happening much faster now in these past few years, and it's a very exciting time. But it's going a bit slower than expected, and partly that's related to the type of data and the liberation of data and how we use that data for research, how we innovate with it. So I want to talk a little bit about the tools, but also talk about how we all fit together. Healthcare is very complicated. It's very different in different parts of the world, but there's a lot of the same challenges wherever we may go. And not one entity is going to sort that or lead that or fix that. And so some might say like, oh, Apple's a big company, why don't you sort that? Or why doesn't amazing universities like Loyola sort this? But in reality, we have to all work together, and each has a different part. And if we try to duplicate each other's parts, it's gonna go much, much slower. And I think that's sort of reflective of how the last 10 years have been. I think the next 10 years are gonna be a lot more exciting due to conferences like this and meetings like this where we're all together exchanging ideas and understanding how the pieces fit. So when defining the community, what is the community? We are a consumer electronics company. We don't consider ourselves a medical technology company or anything along those lines. We make stuff that people like. And for that reason, that stuff is with them, is with you a lot of the time, sometimes all day and all night. And that leads to special privileges or special opportunities to look for patterns or different things that one could surface to a user. But what we call our consumers, what we call users, you might call patients in this model of how we're defining community. And so here we're going to build a Venn diagram where we're talking about where technology fits, where research fits, how we all come together. And for here, the patients and technology, we're talking about empowerment. Now, you can't empower a patient unless you consider their clinician as well. If your Apple Watch sends you a notification that says you might have atrial fibrillation, you're empowered now. That's not true, right? You need to be able to close the loop. You need to be able to take those next steps, and ideally early in the process with you having control over that process. But the clinician is a critical part of that community. So for consumer electronics companies, that means we need to think of how does that data fit? How do these pieces come together? How does that user take this sheet of paper or this screen and allows these next steps to happen? And of course, clinicians work within health systems. We're all familiar with health systems. We think about outcomes, economics, efficiency, how all these pieces fit. And really, where the Venn diagram overlaps for empowerment, efficiency, and economics, that's where technology can play a big role. That's where things can be expedited. But right in the middle of the Venn diagram is research. Each of these circles can't stand alone, and no one owns all of the circles. So we really have to come together and show, how does this message, how does this notification work? How does one get empowered? How does this change outcomes? And that means lots and lots of research. And that means everyone in this room needs to have the ability to do that at scale across every population, across multiple countries and geos around the world. Means we have to have the tools and be able to use that data. So Apple, again, is a consumer electronic company. For all disclosures, I work for Apple. We sell devices, and our goal here is to empower you to be at the center of your health and to live a better life. So again, one can't do that unless we think of every part of that community, but this is where we focus. We are the consumer electronic company. We're very much in that patient circle as our primary focus. And again, our devices are with people sometimes all the time, sometimes all day and all night. So we have lots of opportunistic looks that are passive in the background where you can surface something to a user who bought the device for a completely different reason. And so that's slightly different, actually quite a bit different than a screening test or a diagnostic test or something along those lines. So we'll talk about that a bit more. So here we have examples of sleep, menstrual cycle tracking, looking at your vital signs while you sleep. But again, there's all sorts of opportunities. There's all sorts of places to put sensors in the device, how one interacts with the device, how do they log their medications, where do they keep their health records? Can they combine all of their health records in one place with one device that's with them at all times? And how does that span across the ecosystem of devices they have? They have a MacBook, they have an iPad, they have an Apple Watch, they have AirPods, whatever it may be. How do you unite someone so you understand that pattern, that person, rather than just a device? Before we dive into the specifics of that, I do want to talk about our philosophies and what's really important for us. We need to make sure everything that we ship within the health and fitness space is grounded in science. I need to be able to come to a room like this filled with experts and explain how we made the decisions we made, how did we come there, how do we know that it works in 150 plus countries around the world, how do we know that it works across different skin types and different environments and different temperatures and all of those sorts of things. And so having that open relationship with the scientific community to say, here's how we made this decision. How do we make sure that everything we surface to a user is actionable? You all have devices. You all know what a notification is like. It's a very personal relationship for us with our consumers. If we surface something, we don't want to be more noise, giving you something that's not actionable or perhaps is scary without any next steps. So anything that we surface needs to have clear next steps and be usable and be important to you. And privacy is at the core. That's really difficult for sharing health information and making health information empowered. How do we do that? How do we do that in device? How do we do it so Apple doesn't see it, right? It's not our data. How do we liberate that data but not see it? How does it not live on our servers? How does it all happen on your devices? That's a tricky intersection for research. And we'll talk a little bit about our timeline, but that was challenging for us. When we realized there's health data there and that health data is usable, we couldn't just sum it up and give it to the AHA or the World Health Organization, whoever else might be looking at this. It has to be under the user's control. And that's really challenging. We think we found a really cool way to do that and want to share more about it, but it's difficult. All right, so we're talking today about cardiovascular health. Of course, we have health features across 18 plus different areas, but I want to talk a little bit about this timeline of the heart. So secretly, Apple Watch wasn't meant to be a health device. The health team at Apple was an entire accident. We were meant to build a world-class fitness device. And to have a world-class fitness device, you have to have really accurate calorimetry, which means you need to have really accurate heart rate sensing. And so early users were having heart rate and noticing trends in their heart rate that they'd never seen before. No one had ever had a heart rate every 7 minutes. We'd had it when we go to our doctor's office. We have it maybe if we're feeling some symptoms at home or whatnot. But seeing every 7 minutes and during activity every 7 seconds was mind-blowing, was opening to help users realize what normal is for them and where perturbations in normal could actually mean something. They were taking this information in and seeing their doctor, or they wanted to do other things like share that data with other apps on their device. And heart rate being health data, again, can't live on an Apple server. We don't actually want any data on our servers. We really respect this privacy at the core. But how do I, as a user, share my heart rate with another app on my phone? So that was the advent of Health Kit then. So once heart rate came out, there was a realization there's an opportunity in here in health. And Health Kit, you can think of as a secure spreadsheet on your device where you can pick and choose data elements to communicate between apps on your phone. And that means it doesn't have to be just factors or metrics from the Apple Watch. It could be from anything. It could be a continuous glucose monitor. It could be a scale. It could be a blood pressure cuff. It could be a thermometer. Whatever it is, you suddenly are in control of your data and can move this around your devices. We have two journeys kind of in this timeline. So around 2015, after the heart rate app was shipped, we also shipped Research Kit. And the idea here was a lot of these early users, again, were saying, I have so much data amassed in my phone, I want to share this with my doctor, or I want to donate this data to research. And Apple had no way of doing that. Again, we don't see it. It's all encrypted, it's all on your device. So how do we empower researchers to get this data with users' permission? So we released something called Research Kit. Research Kit is an idea where you can copy and paste code and build your own app and ask your patients or your participants, can I read your health kit data? It was fantastic. There were some amazing world-class studies that were done at scale, but it's still really hard to make an app. I work at Apple. I have no idea how to make an app. And I've been there for a decade now, and so we'll talk a little bit more about that evolution. But in my mind at that time, the thought was, this is going to change the world, it's going to change how we do research, and everything's going to be different. And now in 2025, it is different, but not as different as I thought it would be. And so I think the next few years are going to be really important. 2017 and 2018, we did something very simple. The heart rate was already there, but now we released a notification saying, your heart rate is high, or your heart rate is low. And so there's numbers, and there's making the numbers usable and making them actionable. But we were getting so many letters from consumers around the world saying, thank you for telling me I was having a heart attack. Thank you for telling me I had rhabdomyolysis. And we're like, we did not say any of those things. We said your heart rate's high. But it was clear that people were finding this very usable, and they were interacting and engaged with their data in a way that we didn't anticipate. And so we started to move more and more down that path, and we started to realize we need to do more and more research at scale. We could look at rate in a very accurate way. We could also look at rhythm. So atrial fibrillation is a very common arrhythmia, and we thought, okay, this is passive, it's on device. Could we find people have atrial fibrillation before they know it? Often it's asymptomatic, it's a leading cause of stroke and other conditions, and so that was the next sort of move. But as Dean Morato said, heart disease doesn't only affect the elderly, it affects all adults, it affects all of us. And so how do we assess our ability to do this accurately in a 20-year-old, the same as we would in a 60 or 70-year-old? And so we needed to do a large-scale study. So that was our move into using Research Kit. We built a study in collaboration with Stanford and the American Heart Association called the Apple Heart Study. And we went and validated an algorithm to look for atrial fibrillation amongst a study population of 400,000 people. We built in a telehealth model, an adjudication model, and it was great. We learned a ton. We were able to ship the feature. That was one of our first regulated software as a medical device feature. And that's sort of empowered our heart journey since then. Subsequently, we released the ECG app, so you could look for one lead ECG as an active task on your wrist. And then later, for those people with atrial fibrillation, they could keep track of their percent time in atrial fibrillation and look at that against other variables like activity or alcohol intake or sleep and otherwise. It sounds very simple in retrospect, but along the whole way, we weren't totally sure our role in this. Are we meant to be, what are we? We kind of consider ourselves an intelligent guardians. Like we're there in the background, we look for things. But again, we're not a screening, we're not a diagnostic. We never actually meet you. We don't actually even see your data. So it's a big deal if we're wrong. If we say, hey, you might have atrial fibrillation, and you don't, that's a problem. If you go to the ER, maybe it affects your life insurance, may affect a lot of decisions you make. So where do we set that operating curve? And so often we really focus on being right, which means we miss a lot of people. Our sensitivity is not as high as it would be for a screening test or a diagnostic test, but we really focus on specificity. And so we really want to minimize our false positive rate. Which means as a company, we can't actually advertise and say, you should go buy this device because it does this thing, because it's not true. We didn't tune the algorithms that way. Again, we're something you wear for another reason. We're in the background and we look for things, and if we see it, we want to be right, but it means our sensitivity will be, by definition, much lower. So what is our role in that then? Where do we fit? And that's still evolving, to be honest. We've had other devices we'll talk just kind of high level about, but ability to predict ovulation in retrospect, the ability to take a hearing test as an active task. And all of those are very different things. They're not all intelligent guardian or in the background features. So how do they all fit together and where are we? And I think we're still evolving and working with all of you to figure out where does all this fit. More recently, we released a signs of hypertension feature. So hypertension, incredibly common, more than 1 billion people affected around the world. About half don't realize they're affected. If left untreated, it can cause or result in a number of different significant adverse cardiac events. And it's silent. It's often asymptomatic. So again, about half of people who have it don't know it's there. So it's a great opportunity for something passive, opportunistic in the background to say, do we see signs or do we see evidence that's there? And so we have this PPG sensor. This is how we measure heart rate. This is how we look at the heart affecting blood vessels in your wrist. So every time the heart beats, we push blood out through our vessels. If there is some back pressure, if your heart has to work harder, that results in high blood pressure. Chronic high blood pressure can result in hypertension. Hypertension is a state of change in the body. Blood pressure is a measure of pressure. We don't assess that. We don't assess volume. We don't assess pressure. We don't assess we don't give you a number here. What we've done is we've trained an algorithm to say, what do the vessels look like in people with stage 1 and stage 2 hypertension, and how is that different from people with maybe mild elevations in their blood pressure or normal tension? And so this is incredibly important. As you can see from this figure, we shine a green light through your skin, and that light reflects off of those vessels and comes back to you. And it assesses variables across 256 different elements and tries to see how is the vessel responding to each and every heartbeat. That might be different for someone with darker skin. That might be different for someone with different characteristics of their skin and sensibility of their skin and otherwise. And so how do we do that? How do we do that at scale? And then how do we talk about that in hundreds of countries? And so it takes a lot of time and a lot of effort. For this particular one, we built the algorithm on training data from over 100,000 consented participants across all body mass index, skin color, age, sex, all sorts of variables and background. And then we validated the algorithm prospectively in 2,000 new participants who the algorithm had never seen to prove that it works. So basically we had people wear the device during daytime hours, check their blood pressure twice a day with an Omron blood pressure cuff, and then look to see against labels of stage 1 and stage 2 hypertension, how do we perform? This was tricky for us because our model had been atrial fibrillation. If we're wrong in atrial fibrillation, it's a big deal. This is different because we should be checking our blood pressure anyways, adults. You can check your blood pressure by going to your local library and checking out a cuff. You can go to your local pharmacy. You can see your healthcare provider. But it is in the guidelines that we should be checking this anyway. And we're not saying, unlike atrial fibrillation, where it's more of an acute interaction, here we're saying you should now go check your blood pressure with a standard cuff and keep track of that data for the next time you see your healthcare provider. So we actually struggled with this. Should our specificity, should our positive predictive value be so high that we're never wrong? Or are we going to lower the sensitivity so much that we miss a lot of people that could be helped? And so choosing that point, and you choose this obviously before your interaction with the FDA and other regulatory bodies around the world and where to set that curve is very difficult. It's something we debate a lot about. But here we achieved a specificity of 92.5%, which is lower than many of other features because we thought we could be wrong a little bit more here because again, we're not activating you into the system, we're asking you to check your blood pressure. And our sensitivity is 40%. So it means we won't find everyone that has stage 1 or stage 2 hypertension, but we'll find a lot of people. We estimate that in the first year of shipping this feature, which shipped as a free software upgrade in September, we'll find about 1 million people who otherwise wouldn't have known they had hypertension in the first year. So it's a great opportunity, but again, very different than a screening test or a diagnostic test where you'd expect a sensitivity north of 90 or higher. And so that's what our feature says. It says, you may have hypertension, you should check your blood pressure. In fact, we'll tell you the best way to check your blood pressure. You can use any cuff. We don't want to limit to a certain brand or whatnot, but it's important that you sit still, put your feet flat. We have all that guidance from the American Heart Association, or wherever you're at in the world, we use the regional recommendations. And then we built a place to log that information. And so you can keep track of this, and by the time you see your provider, again, moving from that empowerment to efficiency for the provider, we'll sum it up, we'll give all the classifications, we'll make it as a PDF you can print, or you can turn that screen around. But within 10 seconds, any provider who's used to looking at blood pressure will say, I get what's going on, let's go ahead and take the next steps. So it's much more efficient. And again, the idea here is this is in the background. We have the opportunity because we're there, we're part of your life, we're a very kind of personal thing. This is happening without you even knowing it, without draining your battery, without doing other things. We have those looks, and if we're not sure, we look again. If we're not sure, we look again and look again and look again. So this particular feature, once you onboard and turn it on, it's looking anytime you're at rest during daytime hours, and then every 30 days it looks back and says, should we notify this person or not? How confident are we to notify? Okay, so that's one example within cardiovascular health. As we talked about, we're in many different parts of your life, including vital signs, women's health, activity, fitness, mobility, and we're able to put sensors in a lot of different devices that are with you. Research. Okay, so we've talked about the patient, the consumer. We've talked about empowering them. Empowering them involves the clinician as well. There is that bridge in all of these areas where the Venn diagram intersects of research. When we did the Apple Heart study, we thought, this is fantastic, 400,000 participants, published in the New England Journal. It was our first software as a medical device. FDA was incredibly helpful, and we're able to do this. Let's just do one of these every year. Turns out it was really incredibly hard. And so we built a research app with the idea we'll do 3 big studies every year. Since then, we're now on our 4th study. So obviously it didn't work out. We shipped this in 2019. It was our first research app. A couple months later, a global pandemic kicked in. It was a fascinating time to be doing big public health studies. We did the Apple Hearing study with the University of Michigan and the World Health Organization. Apple Health study recently launched. That was an offshoot of the Apple Heart and Move study with Brigham and Women's, and then the Apple Women's Health study with Harvard T.H. Chan School of Public Health and with the NIEHS. And these are hundreds of thousands of participants who have no compensation. They don't get paid. They really just want to share their data and help contribute back to the understanding at scale. So there's, again, tremendous opportunities here and opportunities to expand this around the world in different age groups and otherwise. But any of these groups in these slides will tell you Apple's incredibly hard to work with. And all this takes a very long time, and it doesn't go as fast as we'd all like. And so part of what my team does is build tools so that all of you can do research without needing to collaborate with Apple, without having to sort out agreements and doing all these things over months and years. And so we'll talk a little bit about those tools as well. So we talked about the patient, we talked a little bit about the clinician, but again, the clinician needs to understand the science, needs to understand how we got there. And so if you go to apple.com/health, you'll see clinical validation summaries of all of our health features and products and how we got there, how they were validated, and links out to peer-reviewed journals and otherwise. Here's an example of the type of efficiency that we want to create. So if we say, hey, you may have hypertension, you should check your blood pressure. Here's how you check your blood pressure. Here's the appropriate way to do it. We'll even set reminders for you. Then we log it and keep track of it for the user. And you don't have to have received our notification to use this feature. This is just a great idea if you're collecting your blood pressure anyway. But basically, in the top row here, you see the systolic. Bottom row, you see the diastolic. You get all the general classifications here in the US based on AHA guidelines. And then you have it divided by morning and evening. So you're looking at a lot of data, but literally 10 seconds. Most providers who are used to blood pressure will look at this and be like, I got this. I know what's going on. We can continue to track this, which is very different than the current journey in finding someone with hypertension, tracking it, and then taking the next steps. And so we're excited about that. We have that for all of our features, so for ECG, for hearing tests. And this is an interesting discussion for a consumer electronic company when we're integrating with the clinician and making it usable. This really, really caused headaches for our design team. They said, how is a consumer supposed to understand what this means? This looks like a bunch of squiggly lines. How are we empowering people? And so there was actually lots and lots of debate of saying, we're Apple, should we just change the ECG? Should we make it drums? Should we make it colors? We'll make it like really usable so people understand. But the idea was, how is that empowering the clinician? How is that making the clinician have efficiency? Then we have to talk in that language. And so partly is orienting people to what their data means, but also saying, here's how you close the loop with your provider. And that's difficult. So it means in every health product and feature we have clinicians, we have patient advocates, we have human factor designers, we have a bunch of people on the team all the way from prototype phase through post-market analysis. But this was the first one where we really went head to head and said, it has to be this. Even for doctors, this is really confusing. For consumers, it's definitely confusing, but it's the only way to allow that efficiency. And then here's an example from our sleep apnea feature, sleep apnea notification feature. All right, so that's patients, that's providers, healthcare providers and clinicians. Then there's the system, right? So if we can liberate all this data, we can put it even in your EHR, we can do all that sort of stuff. Is that worth it? Are you storing a lot of data? Are you creating liability? Are you slowing down flows? Are you having numbers just for the sake of numbers? And so that's where more and more research needs to kind of evolve around the world. But there's tons of really great examples. This is an example from Ochsner Health out in New Orleans, where they did a home blood pressure monitoring program, again, using that HealthKit system, where HealthKit can write into their electronic health record, and they had folks with hypertension keep track of their readings at home, and they built a very simple dashboard to allow their healthcare staff, doesn't always have to be the clinician, doesn't always have to be the doctor, but someone on the team kind of keeping track of things, able to call the patient, kind of interact with them in between visits, which really empowers and saves a lot of time and effort and money. There's other great examples. Johns Hopkins basically provisions an Apple Watch and an iPhone to anyone that's admitted with a new heart attack, and then they keep track of them for 1 month post-follow-up. They also give them a scale, they give them a blood pressure cuff, they give them a whole suite of products and sort of set it up for them as if they're like an Apple store, and send them home and everything's sorted, and then they're able to keep track of them from a distance. And they showed dramatic decrease in readmissions, significant economic outcomes, and empowerment of the users. So all really great programs. I met the Apple team in 2014. I was at Stanford Children's Hospital. My patients have type 1 diabetes. I'm a pediatric endocrinologist. And so basically we link continuous glucose monitors through HealthKit into Epic, and which is our EHR. And we're able to observe patterns at home and observe trends in between visits. And so previous care was every 3 months. Families would drive up 3-4 hours sometimes to Palo Alto. We'd print out sheets of paper, we'd line them up and be like, look, this is what happened over the last 2 weeks, let's change everything. And then basketball season started, or Thanksgiving happened, or something else. And so we're basically always chasing our tails and always wrong. And so it allowed us to have a dashboard and kind of keep track of things in between visits, but also meant they didn't need to drive up to see us. And so this was sort of the early days of telehealth for us. All right, so It's a very high-level, kind of quick talk about patients, providers, health systems, outcomes, and economics. But how do you all do research? How can you do this? So basically, on users' devices, either on an iPhone or iPad, there's this health kit spreadsheet. You can ask to read data from there. You could also build an app, which I'm going to give more information about because I know it's really hard, but an app that does consent from a distance. So you could see lots and lots of participants doing structured tasks like hearing tests or 6-minute walk tests or whatever it might be, memory tests, conduct surveys with different branch logic. And so around 2020, we kicked off a program called the Investigator Support Program. And the idea here was we had provisioned devices to people who want to go do research, who want to kind of speed things up. And so within this program, and you can go to researchandcare.org in the top right corner. There's a drop-down menu, click Investigator Support Program, but you can apply for Apple Watch, AirPods Pro, Vision Pro, and different devices. And so we did that, and that was great, but what we found was people still didn't really know how to make apps. It was still taking a very long time, and they weren't all getting to know each other or meet each other. And so then around 2023, we started a health research summit much like this, where we brought people in the same room and said, learn, exchange information, figure things out. And they all ganged up against us and said, we don't know how to make apps. You guys have all this cool information, but you're not making it available. So more recently, we have a beta program called Study App Template, where the primary objective was that Rajiv could make an app, which again, I have no coding experience whatsoever. So now, even without Xcode on my MacBook, I can use drop-down menus and build an app and then submit it to the App Store. And again, that reads HealthKit, the surveys, the structured tasks, and whatnot. So happy to send more information to anyone that might be interested. But basically, nothing should be stopping you. You have access to the devices. You have access to the ability to request it. We still have more work to do to make the data more usable. It's a lot of data. It's a lot of information at a very high cadence. But working together with the community, we want to continue to expedite and empower. There's some cool examples of studies. So UCLA is conducting a major mental health study, looking at depression and anxiety and looking at biomarkers of that. There's a cool study, and we love these collaborations, particularly here in the US, but around the world. So this was Texas A&M and Stanford looking at heart changes during fire season. So kind of ahead of the wildfire season, how do you baseline and understand changes, and do those changes persist? And again, this is possible with these devices on person, on your body. So I'll just close again with those ideas of community, technology, and research. So we are the community. All of these pieces fit. This is not a complete model, but these are the three kind of areas where I think most of the people in this room are focused. And right in the middle of that is research and technology surrounding all of that, speeding us up. Apple's not going to do it. Any one group or entity in this room in here is not going to do it alone, but together we can do all of these things. So we encourage you to push back on us, say where the tools can be more robust, how we liberate things for you without violating our underlying principles of privacy and otherwise. But happy to meet with you all and wish you good luck. Thank you again for having me.
Our first panel discussion here is going to be focusing on closing the equity gap in wearables. So first question you might be thinking is, this is wonderful. Can all people have access to this kind of data? So I'd like to introduce the moderator for this discussion, Dr. Miriam Salik, who's the Executive Director of the Ed Kaplan Family Institute for Innovation and Tech Entrepreneurship at Illinois. There you are, Illinois Institute of Technology, and she will be joined on the panel by Susie Monasir, who's Deputy Director for Advancing Health Equity at the University of Chicago. Let me turn my page. And as well as Paula Barnes-Burns, who is the board director at VasoWatch, and Dana Sun, who's partner at Equitage Ventures. So I welcome you all here to the table. Panel.
Everyone, while the panelists take their seats, I might just share a few more words about who I am. So I'm your moderator today. My name is Miriam, and I was part of the launch team at Matter, so I'm really excited to be here and see some of my former colleagues. I've also worked with a number of you in the audience, so it's very nice to see you again. I currently am running the Entrepreneurship Institute at Illinois Tech, where we are responsible for, moving people from the bottom 20% of the income bracket to the top 20%, primarily through a tech-focused education. So Dr. Kumar, if you ever wanted to build an app, you should come and spend some time with us. And so we're taking that calling and using it to really think about how we want to upskill the healthcare workforce and improve their digital competencies. So I'm really excited to be here today to talk about advancing equity and by using wearables. We have an incredible group of experts here to provide different perspectives on this topic. We've already heard about your titles, but perhaps we could go and get a little bit of introduction and help the audience understand how closing the equity gap in wearable technologies is relevant to what you do. Let's start with Donna.
Hi, great to see everybody here. My name is Donna Sun. I'm a partner at an early stage venture capital fund called Equitage Ventures. Equitage is a word that we created by combining the terms health equity plus age. So our fund focuses really on investing at the intersection of senior care and technology innovation. But really, as you think about it, when people think of elder care, I think they're thinking of aging at home and maybe somebody in their 70s and 80s. But the reality is all of us are aging every single day. So it's actually a much broader topic than it is. So it's really about healthy aging. And of course, women's health is also one of those areas within healthy aging, especially since, well, half the people around the world are women as well. But as we've talked about earlier, right, it's so under-researched, underfunded. And so for us, we want to think about, especially the intersection of women's health, healthy aging, that could be diseases that affect women disproportionately, like cardiovascular, like neuro, like autoimmune diseases, and beyond. And so this is one area where we want to be able to call more attention to the equity gap from both the aging angle and from the minority angle as well.
Thank you, Donna. So Paul, we're going to skip you really quick because I want you to do a little bit of a deep dive on VasoWatch. So Susie, let's have you introduce yourself.
Sure. Good morning, everyone. My name is Susie Monteser, and I'm at the University of Chicago, Deputy Director of the Advancing Health Equity Program. So the program is based at the University of Chicago, but we actually we partner with 3 other organizations. So the Center for Healthcare Strategies, the Institute for Medicaid Innovation, and the Justice Collective. And we do a lot of what Dr. Kumar was talking about is bringing together different stakeholders that are working to advance health equity. So our partnership that makes up the program, we have a lot of different experts on our team related to payment, related to clinical transformation, as well as expertise related to partnering with patients and communities. And we work specifically with teams all over the country that are made up of those kind of similar stakeholders. So each team has a state Medicaid agency at the table, at least one Medicaid managed care organization or a Medicaid health plan, as well as at least one healthcare provider organization. And more recently, many of our teams are working really hard to bring community-based organizations as well as patient voice to the table. And so these teams are working to transform how care is delivered to address inequities in their states and communities, and they're doing that by integrating payment reform. Our program studied health disparities for a long time and came to a realization several years ago that none of this is going to be sustainable if the payers aren't at the table and payment reform isn't integrated. So that's really the focus, is bringing together those stakeholders to make that change possible and sustainable.
Thank you, and we'll hear a lot more about that. You know, it's one thing to innovate, it's one thing to invest in startups, but for these ideas and solutions to get to market, you really have to think about payments and a number of other issues that we'll talk about today. So next up, we'll have Paula. So please introduce yourself and tell us a little bit about VasoWatch.
My name is Paula Barnes-Burris. Good morning. I come from a background of over 20 years of experience among Fortune 100 companies in corporate development, finance, marketing, and strategy. I'm currently a director with VasoWatch. VasoWatch is an early-stage maternal health technology company focused on predicting postpartum hemorrhage, which is one of the leading causes of maternal morbidity and mortality, particularly among women of color. The company uses a 510(k) cleared wearable that streams heart rate, maternal heart rate data to our proprietary algorithm called Vibrant, and that identifies physiological signs of uterine atony, which is, it accounts for almost 80% of postpartum cases, postpartum hemorrhage cases. And I'm going to say the solution is to provide advance warning to clinicians so that they can be prepared for their patients' stress that may come from experiencing postpartum hemorrhage. And also, the goal is urgent and it's simple. We want to avoid mortality and morbidity for women. What else I want to say here? The company started maybe about 3 years ago, and our focus is to raise money right now. We are encouraged with our recent investments. We are finalizing investments with Vanderbilt University Venture Fund and Ben Franklin Technology Partners, and that momentum among potential investors signals that, you know, there is confidence as well as interest in this technology. We also look to improve in many areas for maternal health. Thank you.
Thank you, Paula. And as a reminder, Paula is the board member of VesaWatch, and so you're exactly the type of board member we'd like to see among startups. You know, very involved and informed, and so thank you for representing VesaWatch today. Okay, so you can see we have different perspectives in the room. So the perspective of an investor, the perspectives of an innovator and a startup, and then the perspective of someone who really brings the different stakeholders together to really get these innovations to market and address the systemic issues in translating innovations to market and making sure that equitable access to care is achieved for these new solutions. So let's start with kind of funding. So Donna, I'm going to turn to you. So from your vantage point as an investor, tell us why it's good business to invest in women's health.
Sure, happy to. So I'm going to actually start with the business case because I think you got to lead with quantifiable ROI before talking about the moral obligation there. But the reality is we all know, right, that less than 2% of venture funding goes to women's health-related companies. It's not great. Those are the statistics. My perspective is when there's very few people chasing area, it's actually a market inefficiency. It's an arbitrage opportunity. That means that unlike a lot of overhyped AI areas, which are getting insane valuations, if you go after an overlooked area that clearly is addressing a real clinical need and there are real buyers and real users in need of that solution, right, you actually could get a pretty good deal. Well, yes, also doing a good in the world as well. That's genuinely how I think about the women's health space. So I actually think that it's a good, smart move because you can get really great financial terms for a real market need where there's a de-escalation opportunity that's present there. So that's opportunity one, is look where others aren't choosing to put money towards because it's a more savvy investment decision, kind of a value play. The second reason there is the reality is because so little funding, goes towards women's health companies, this also means that most venture funds' portfolio have very little exposure to women's health. So from a diversification perspective, again, we know that it's a massive growing problem. Over half the people around the world are women. This makes over $500 billion of medical expenses in the US alone. This isn't a small market, right? So if you want to also think about diversifying risk in your portfolio, again, to me, it's just a smart business choice to be adding a women's health bet in there as well. And then thirdly, yeah, I think it's the right thing to do. But when you lead with that only, it's just not a strong enough case. So that's why I'm saying if you're trying to think about it from a portfolio perspective, there's a lot of reasons to be looking at making women's health bets.
Thank you. I mean, it seems almost silly that we have to call this out, right? We are, but thank you for that. So Paula, your VesaWatch is addressing a women's health issue. And I think we got the understanding of the technology. I wanted to ask you a quick question. So some people don't don't know what it means. Like postpartum hemorrhage is sometimes hard to understand. We talked about this, yet last night. What do we mean by postpartum? Can you walk us through a case study like of a patient, of a woman in postpartum who goes through blood hemorrhage? When does it happen? And how does VasoWatch actually prevent it from happening? And what's the intervention?
Okay, so first of all, patients are, when they go to the hospital, they are actually given a survey to determine the risk of postpartum hemorrhage. And most patients, in fact, about 40% of those who are identified as low risk actually advance to actually having a postpartum hemorrhage. And when they, with the VasoWatch device, they're able to detect that at least up to 2 hours in advance, which allows the clinicians to prepare either by having a uterotonic available, or they can have an additional IV available and be able to look at the woman's history and have everything in place before it actually occurs. I mentioned uterine atony and representing almost 80% of all postpartum hemorrhages, but they can also be caused by trauma tissue and what's called thrombin, the remaining 20%. And this is probably, it is more prevalent among women of color, 3 times as more so than white women. In fact, severe maternal morbidity and mortality is experienced more in the U.S. than any other country in the world. And that's kind of surprising given all of the advanced technology that is available to us here. With this technology, clinicians can, like I said, prepare earlier, but can also prevent for the hospital other things that happen as a result of postpartum hemorrhage that's very expensive, like transfusions. And then if it leads to mortality, death, and this from a business case, it is very important to stress that improving outcomes is just as important as providing a solution for PPH.
So Paul, we'll stay with you for just another minute. So we're talking about investing in women's health. So Christine Rohan, your CEO, has raised about $400,000 towards supporting a clinical trial that you're about to launch in January, correct?
That's correct.
So in that fundraising, has she had any challenges in positioning the opportunity? And what are the types of conversations that she's had with investors, and what was the hardest thing to convince them to do? Yeah.
So we are looking to raise an additional $400,000. We've already raised close to $600,000 from the 2 investors that I previously mentioned, Vanderbilt and Ben Franklin Technology Partners. The remaining $400,000 is for a clinical pilot. And we have to address with our potential investors any doubt that they may have about this being a business case to improve outcomes, as well as familiarize them with the value in improving clinical workflows.
Thank you. All right. So Susie, we're going to turn to systemic issues that might drive inequities and access to innovation. So how do health plans, providers, Medicaid agencies, how can they come together to change what is paid for in healthcare? Help us understand how you do that, and maybe some ideas you have around how we could even do it better.
Sure, happy to. It's very complex conversation. I think we could spend all day talking about this. So maybe I'll just give a couple of examples, and specifically where our work lies is in Medicaid. And so I think a lot of things are transferable in terms of learning. And when it comes to Medicaid, specifically when there's going to be a change made in terms of how something is paid for, it has to happen with the state legislation first. And so sometimes it can take a long time to get decision makers, policymakers on board with what should and shouldn't be paid for. And obviously, we're in a very interesting time right now, particularly for health, public health, equity. And so it's, I think, probably one of the most challenging environments right now for Medicaid and anyone who's working in this space. That said, once those decisions are made, alignment is absolutely critical, and that's partly why our teams in our Learning Collaborative bring together the state Medicaid agency representatives, the health plans, as well as the provider groups, because a lot of times organizations are creating ideas, are coming up with ideas for innovation and change in a vacuum. And so if they're not aligning together and they're not coordinating in terms of what goes in their contracts and what's paid for, then oftentimes things don't go anywhere. And so in an ideal world, we're talking about value-based payment or alternative payment models in which providers, organizations are incentivized to reduce disparities and to improve health outcomes. And so that's one component. And then the other component I would be remiss in not talking about is how do we demonstrate value? And so a lot of times in equity work, change takes a long time. And if we're only measuring traditional ROI, there's going to be a lot of disappointment, frustration, and things, might not go anywhere. And so a lot of our teams are encouraged and are thinking about, what other areas of value can we demonstrate? And so social ROI is one example. There's a lot of different ways to talk about it. And I think making a business case for that and describing, what are all these other positive outcomes that can come from this change to our care delivery, to this intervention that maybe won't be seen overnight. And so a specific example that comes to mind for me, one of our teams, one of our states, in their early days of their intervention were, really focused on chronic disease and, had this kind of light bulb moment where, when we're talking about managing diabetes, when we're talking about managing hypertension, all of those things can't happen if someone doesn't know where they're going to sleep each night. And so they actually moved way upstream and started focusing on housing individuals who are on their Medicaid health plan. And so through their pilot intervention, they saw some really amazing outcomes. And so I think it's been running about 3 or 4 years now, and they see reduced check-ins, reduced admittance to jails and prisons. They see reduced emergency department utilization. They see reduced inpatient stays. And there's a lot of other things that are happening downstream. And so for them, it's really about articulating this much broader picture of health, and not everything needs to happen in the clinical setting. And so that's one, I think, really interesting example.
That's great. Thank you, Susie. That's really helpful. So I wonder if we could stay with you for a moment, and let's take Vesta Watch as an example. So there's a device and there's a service. So for those who aren't familiar with how these services or devices are paid for, what's the difference between how these services and products are reimbursed if they're reimbursed through private health insurers versus, say, Medicaid?
Yeah, it's a great question. So we typically see that reimbursement rates are a lot lower for Medicare and for Medicaid, and so that presents another real challenge. There are some, I think, promising opportunities. I know there's been a lot of work around continuous glucose monitors and expanding access and coverage through Medicaid. And Medicaid, I'm sure most folks in the room know this, but every state has different benefits, coverage, and so it really just perpetuates those inequities across the country. And so one of our partners, Center for Healthcare Strategies, has been leading an initiative to really figure out how do we expand coverage and access to continuous glucose monitors, which we know through lots and lots of data that improves outcomes for individuals with diabetes. And so they've been running a learning collaborative, might not be the exact term, but they've been basically looking at this across a number of states. And what they've been finding is that there isn't one single solution, one single answer to how to do this. But some of the early learnings, I think a lot of it always comes back to data and demonstrating the effectiveness of what we want paid for, and really making the case that that effectiveness goes beyond just diabetes. That really can improve an individual's life on so many different levels. It's the right thing to do. We've also seen some success with just really listening to patients and individuals living with those inequities. So bringing folks to the table that have diabetes, that have been living with it their entire life, and understanding just how complicated and how it impacts every aspect of their life. and what their health plan ends up paying for as a consequence of not having their diabetes under control. And so I think those are two things that we tend to hear a lot about, is just really studying the data and making projections around how one intervention can impact on so many different levels, and also just really being sure to sit down with individuals that are living with these inequities and really understanding what does their day-to-day look like. Clinicians, providers, systems, we tend to see folks for, I don't know, an hour once a year, maybe, if someone has a chronic condition. And so we really don't have insight into what's going on in thear life from day to day.
That's a really great point, and it brings to equitable access to care. Part of the story is affordability, but then there's all these other challenges that you have to think about, including trust and kind of other challenges to adoption around literacy, and also the stakeholders that are supporting the care of the individual. So, Paula, with VasoWatch, you haven't started your clinical studies, but you've been in hospitals and you've talked to maternal wards or people who work in maternal wards, and so what aside from affordability, what are some other challenges that you might perceive in the technology being adopted, given what you know about how it's being used today? Pre-market.
Thank you. Let's start with trust. Trust is foundational, and many women of color distrust technology due to historically that technology marginalizing their voices. So for a device like VasoWatch, which continuously collects physiological data, the first thing is that it has to demonstrate clear clinical validation, privacy protection, and equitable outcomes to not only gain the confidence of patients, but of clinicians. I would also say digital literacy. It's uneven across age, income, and education levels. So maternal care wearables have to have onboarding, user education, as well as clinician-supported engagement. Those three things are essential, at least what we've seen. And then the last thing would be data bias. It is an issue in digital health, and our algorithm called Vibrant, it relies on core physiological data signals rather than phenotype data, and it also mandates that we collect diverse information in order to ensure equitable performance.
Thanks, Paula. So Dr. Kumar earlier kind of had mentioned about their, wondering whether they should change the electrophysiological signal to a drum beat to make it easier for patients to really understand what's going on. So in this case for VasoWatch, it's a sensor among many that are used to sense vitals of a mother, and the signal is being observed by a nurse, correct?
Right.
And so help us understand the mindset of the nurse as they're trying to make sense of all of these different signals. Is this easy for them? Is it not? How? Yeah.
Well, the nurse already has other things that they have to watch for, and in particular in the labor and delivery, many patients could arrive at the same time, and so, prioritization in terms of care could be an issue, but what we want to do is make sure that our wearable is, and the information, the signals is, and the data that's collected is able to be integrated with existing tools that the nurse already has before her, and especially on the screen that has all of that data. So it allows them to be able to manage their workflow better, and also to have access to the patient, and the patient also has the information in front of her as well.
Great, thank you. So Donna, we're going to come to you. So first I'm going to ask you, you're getting started with your fund, and can you give us an example of a startup that kind of is particularly exciting to you and might advance access to care? Or
we've made 3 investments in our fund so far, although candidly I will say they're not yet in a wearable technology space, so I don't want to derail this too much. But one that's adjacent is anytime we think about aging, I honestly think that women are the face of aging, both because they're living longer than men, right? On average, men are living until about 76-ish years old. Women are 81-ish years old. And just in those couple years alone, there's also several $100,000 of additional just life expenses to survive as well. And so to your point about affordability, not just quality of care, those are all different considerations that are really adding stressors onto one as they age as well. And so women are also oftentimes the primary caregiver for their families as well. So on the caregiver burden side, which we think is just as important as helping the patients themselves here, we were looking at different types of solutions that really enable them. So one of the companies that we invested in is a New York-based company called Alden Health, and their whole goal is to be able to optimize the 24/7 autonomous shift coverage for the placement of different types of caregivers. In particular, we work with home care agencies on that front as well. So that's one way that we are indirectly, I guess, helping broadly the health of women is by better enabling caregivers, which is better supporting the workforce that's working so hard to support health of all people, both women and men combined together.
That's great. That's a great example. All right, and I'm going to stick with you for a minute. So how do you balance financial performance and social impact in your work? And, how do you make that case to your limited partners, since you're really trying to invest in solutions that support underrepresented groups today?
I would say, I guess I sort of answered that in my opening salvo, if you will, so I don't really want to repeat that too much that's there. But again, from an investor perspective, I think you got to show that different types of social causes, you have to lead with a business ROI. That's just how you get people to not only pay attention the first time, but pay attention the 5th, the 10th, the 20th time. That's there. So if you can't show the clear clinical need, the economic reasons supporting that in the market tailwinds, like how the NIH, the CMS, the FDA are all having different types of mandates, right, that are basically mandating or requiring women to be involved as part of these different clinical studies, or looking at specific quality measures for maternal health and beyond, right? You got to think about all of those for why there's a good business case and also the why now. So I would say I treat it like any other investment decision, because I don't want women's health to be viewed as a charity case. That's actually hurting it. So this is why I'm saying you have to, at least from an investment perspective, we have to lead with the business ROI first, and then that gets people to be willing to think about the social ROI.
Thank you, and you're right. You did mention this earlier, and I just I completely agree with you. And if anything, it's an untapped market, so there's plenty of opportunity to build great solutions for women. So I'm glad that we're doing this. All right, so I'm going to turn to the audience. So we have quite a few questions, and if you haven't had a chance to ask your questions, you can use the QR code up there to answer some questions. So the first question comes from Artie Barnes. How sensitive, accurate is VasoWatch in detecting PPH?
So VasoWatch, compared to traditional vital signs, blood loss, based on the observational information we have, it is accurate in terms of the studies that have been done in Pennsylvania, at one of the hospitals in Philadelphia, and we know that it represents 10 times improvement over measuring blood loss.
Thank you. All works. So there's so patient engagement is key as a wearable. Why have payers limited reimbursement to low-cost devices? And why has Medicaid in Illinois not mirrored Medicaid RPM billing? I guess that's for you, Susie.
Can you repeat it one more time?
Yes, I can. All right, so patient engagement is key as a wearable. Why have payers limited reimbursement to low-cost devices? And why has Medicaid in Illinois not mirrored Medicare RPM billing?
Yeah. So I 100% agree. Patient engagement is key. I'm not an Illinois state Medicaid expert, so I don't know that I can speak to what's happening in Illinois specifically. But as I did say earlier, a lot of these decisions have to happen at the state legislature level. And it can take a long time for that change to happen in terms of what providers, payers, health plans really want to see and what they're advocating for. So I think that's part of it. I don't know if there was a question in there around patient engagement.
Why have payers limited reimbursement to low-cost devices? I think that's probably good enough, unless
Okay.
if the individual who asked the question might want to
Maybe expand.
say something. So here's another one. What structural barrier to equitable cardiovascular care is the ecosystem not addressing enough? And what step could organizations take in the next 12 months? So structural barrier to equitable cardiovascular care. What comes to mind?
I mean, I think one of the first ones I think about is one that we've kind of already talked about, which is just poor reimbursement infrastructure that's there. And so, again, we need to continue showing the healthcare economics rationale for why earlier personalized intervention is able to reduce a lot of the subsequent medical expenses, whether it's things like avoidable postpartum hemorrhage cases, for instance, or the fact that half of women are misdiagnosed following a heart attack, right? Like these are all things that we should be able to be addressing. So I think part of it is reimbursement, part of it is also, unfortunately, I think that there is an inherent clinical bias when it comes to how we're assessing and screening for women, in particular women's cardiovascular health. Number of times that, I've talked to my female friends, and when they go in with cardiovascular diseases, and they come out of their doctor's visit and they get prescribed lifestyle changes, whereas a similar male counterpart with similar problems gets prescribed an actual medication, right? It's just shocking. Now, I'm sure there's other reasons behind that, but it's just one example of how there's still a lot of clinical bias, even in our system today. That's part of the bigger issue that we have to address together.
Education is definitely necessary. Susie, any thoughts on your end? So if you're an innovator and you have a solution that might predict or predict a condition before it's too late, how does the innovator participate in the conversations that you're having with health plans?
Yeah, so I think the innovator is any way they can get to the table to have conversations with a healthcare system or a health plan that's thinking about addressing the same issue. And so I think that's partly why we try to bring together these various stakeholders, because oftentimes we'll see in a state that there's lots of different groups working on the same issue, but they're not working together. And so they're kind of independently trying to solve for one specific area of the issue, but not figuring out how to integrate and work together. And so I think just kind of going back to the earlier point, the thing we see that's missed so often is the patient perspective. And I think a lot of times in healthcare, we're trying to move things quickly as we can. And with work around health equity, we have to slow down. As frustrating as that can be, as resource intensive as that can be, the longer term results are going to be so much more fruitful. And so it might take a year or two just to establish a trusting relationship with individuals, with patients who are experiencing hypertension, perinatal hypertension, diabetes, heart disease. And so I think a lot of times there's not investment into how long it takes to build relationships. And a lot of times we've seen innovators, as well as providers, as well as health plans making a lot of assumptions and using individuals in their sphere as a proxy. So, we have a Latino provider on our healthcare team. He's going to speak for all Latinos in our state that are experiencing hypertension. It doesn't work that way. And so a lot of assumptions are made, a lot of things are rushed through. There is not a lot of investment in really hearing the patient perspective and voice. And it's going to look very different from community to community. And so we can't just say, University of Chicago, this is what you need to do for all your Black patients that are experiencing high blood pressure. It doesn't work that way. And so really getting to the individual level and really taking the time to sit down and have conversations with individuals after that trust has been built, which Paula was talking about, that trust piece is so critical. There's a lot of mistrust that can already be existing between individuals and their health plans and their providers. And so really figuring out like who is the person that is going to be able to build that trust and maintain that relationship for the long term.
That's a really great point. And I did want to, I had a conversation last night about the Institute for Translational Medicine, and they had some grants that they would give out to innovators to help them engage with the community. Because one thought that comes to mind is, startups operate in a pretty lean way, and doing all of that community engagement to support, understanding how their solution would be adopted and used by different stakeholders takes a lot of money. So, there's this question of like, who's going to pay for that? And it's nice that there are some grants available for that type of work. All right, here's another question. So what metrics should we stop using? And what new measures should we adopt to close equity gaps and track progress across diverse populations? So maybe that's also, I'll turn to you, Paula, and think about like when you're thinking about this clinical study, what are some of the metrics that you're using? And how are you ensuring that different populations are represented in your clinical study? By your choice of site and
Site choice is definitely one that we have to consider as we look at rural populations, minority populations, and then, hospitals that serve people that do not have traditional insurance, may be relying on Medicaid. So we want to make sure that we have a diverse representation of patients. We also want to address the difference in income levels and what that means in terms of those that may participate. And then education levels is another thing that we have to consider.
And what are the metrics or KPIs for your study? So for your clinical study that's coming up in January, what will you be measuring?
We will be measuring heart rate data information that would be streamed to our to the algorithm, and we hope to be able to consistently show that race doesn't matter. During the pandemic, there was issues with the pulse ox because the way it monitors the melanin was an issue for people of color because of the light absorption. So we made sure that we look at physiological signals rather than any phenotype data, because we know that the majority, or rather women of color, are impacted most by postpartum hemorrhage.
Thank you. So Donna, this is probably coming from a startup. Do you only invest in women-led companies? I think the answer to that is no. Right? And then what stage companies do you invest in, and what size investments do you make?
We'll invest in women-led, men-led companies, so very open to the founder background and profile that's there. In terms of stage, so we do look for a little bit of early commercialization. There's not a strict threshold, but we are mostly a seed and Series A stage investor. Our first check was as low as $500,000 up to $2.5 million first check in. We can lead or co-lead or participate as part of the syndicate. And then I also always get the question, so what else do you bring to the table beyond your money, which is a totally fair question that I'm happy to answer. So we're very grateful to our wonderful LP base. A lot of them are strategic operators and executives from health systems, from health plans, and also in the post-acute world. A lot of long-term care and aging folks. So for instance, home health, home care, senior living facilities, SNFs, hospice, you name it, and they've been very active both in supporting us in diligence and yes, in being some of the first pilot or commercial customers with the portfolio companies that we end up working with. So our goal is to bring their expertise and their distribution moat to you as an advantage once we partner together.
Thank you. All right, here's one last question before we close out. So how are apps being tailored to rural communities with low broadband access? Has anyone thought about this? Maybe Susie, in terms of just making sure, or Paula even. You know, most rural hospitals do have access to wireless.
Is the question about the user, the patient, or about the healthcare system?
Didn't specify, but essentially, if you're using wearables to monitor a condition, whether it's at home or in the clinic, and broadband access is not available, what's an alternative? And the device itself could probably have some functionality, and then the issue would be, how do you alert the provider, right? So maybe more thoughts about that? No? All right, let's move on to the next one. What level of validation is expected from a wearable startup to understand its social ROI? Anyone want to? So how about let me turn to the audience, and any questions come to mind? Maybe we can get an actual question. Have somebody come and. No? All right. Yes, absolutely.
Wait, let me get you your microphone, please.
What you were talking about, as well as our previous speaker. Oh, thank you. Thank you. I'm curious how you're making decisions if it's the target customer is a patient or a consumer, because that puts the wearable in a different context and then will translate down as to different kinds of equity considerations, insurance versus out-of-pocket or broadband, et cetera. So how's the startup community thinking about that problem when they're at the design phase? Do I do it clinically or do I do it consumer-y?
I mean, I just want to be, I'm not the operator here, so I could be dead wrong, but in my experience working with different portfolio founders, our North Star has generally always been focused on the clinical need first. So you got to start with a clinical model that actually works and has meaningful outcomes. And I don't just mean statistically meaningful, they've got to be clinically meaningful outcomes. There's a big difference there. If that works, then the next question is, how do you layer on the optimal business model? How do you monetize this, right? In a way that's aligning incentives between payers and providers and patients as well. So sometimes one works, like the clinical model works, but it's really hard to build a viable business model. Other times you can build a business model, but the clinical model is not meaningful, or it's way too commoditized. I think the really tricky part is finding one that can fit both. That's not every business. So that's why, in my opinion, not every business needs venture funding, because we have insane growth expectations. There's other sources of financing, like grants, et cetera, and beyond as well. But if you want venture funding, we're going to be looking for clinical and that business model alignment that can really justify not just hyper growth, but again, in a way that's actually changing the clinical paradigm for that patient population.
All right, well, that was a great way to wrap it up. Thank you so much for your time and for sharing your different perspectives on this very important issue. I did want to call out that at the health conference just a few weeks ago, we had a big announcement to a large audience about a women's fund of funds led by a woman called Jessica Federer. And so I do think this is the time to really invest in startups that address individuals who haven't really been serviced in the past, including women. So I was really excited to hear about that. And thank you for all the work that you do to advance equity and access to care.
All right, hello everyone. Oh yeah, it's working, good. Hello everyone. So in this panel, we're gonna talk about AI, in particular generative AI, and how it relates to cardio other domains. For this, we have with us Dr. Tachi Okuosa from Rush and Dr. Arun Jayaraman from Northwestern. So it's a very Chicago panel. So I will have them introduce themselves, give a few examples of what they do in this domain. so that you can know them better, and then we're going to go with questions. Tachi, please.
Yes, hi. My name is Dr. Tochi Okwuosa. I'm a cardiologist at Rush University Medical Center. My focus is cardio-oncology, and I'm the director of cardio-oncology at Rush University Medical Center. My focus when it comes to cardiovascular care and cardiovascular disease amongst oncology patients is really to study risk factors, risk assessment with respect to cancer therapy. And the general idea is that we know that heart disease is the #1 cause of death in the US. Cancer is a close #2 cause of death in the US. And amongst cancer patients, their cancer therapies increase the risk of cardiovascular disease, so that if you removed new malignancy or new cancer and recurrent malignancy or recurrent cancer, cardiovascular disease is the #1 cause of problems in this population that is mostly due to the therapies that our patients receive. And so he had asked me to also talk about how AI ties into all of this. From a cancer standpoint, we know that there's a lot of progress that's been made with precision medicine amongst in the oncology world. And precision medicine is the reason why there's been a lot of advances in cancer treatment, such that now we have a lot of cancer survivors. Cancers that used to cause deaths in the past, actually patients are living with those cancers because of all the progress that's been made with respect to precision medicine, targeted therapies, immunotherapies, and so on that we're using in cancer. And then from a cardiovascular standpoint, cardiac biomarkers like troponins and BNPs and other newer biomarkers, imaging, cardiac MRI, echo, strain imaging, and so on and so forth, are all what we're doing in cardiology and using it to gather data now, right? So I think that in future, cardio-oncology is a good marriage between both fields in the sense that we can actually use the precision of oncology and all the biomarkers and cardiac markers and imaging markers that we have from cardiology to create training data sets and basically be able to marry the two in order to predict risk in future and predict how cancer therapies can influence cardiovascular disease and how we can predict disease in future for our patients moving forward so that we can level the playing field or at least reduce the risk of cardiovascular disease associated with cancer therapy.
Thank you. And then Arun.
My name is Dr. Arun Jayaraman. I'm a professor of physical medicine and rehabilitation, physical therapy, human movement sciences, and medical social sciences at Northwestern University. I'm also the Chief of Technology and Innovation at the Shirley Ryan Ability Lab. We're the largest and top-ranked rehabilitation hospital in the United States. We see over 60,000 patients a year. I also run a tech immersion clinic, which is specifically focused on the implementation of technology into clinical practice. So I see a wide range of patients, starting with stroke, spinal cord injury, Parkinson's disease, MS, transplant patients, cancer rehab, to newborn children, to children with cerebral palsy and other developmental disorders. So one of my jobs is to take technology and implement it into clinical practice. So that can start with companies who are startups to large-scale companies who are interested into entering into the medical/rehabilitation phase. Things like we help companies move through fundraising, go through the CE mark or FDA approval, try to go to work with CMS to get yourself a new HCPCS code or a different reimbursement code. At the same time, that allows us to get our patients access to the latest technologies so that our care models are constantly evolving. We have a flagship hospital on 355 East Erie. If you've never seen it, it's a beautiful hospital. You should come and see it. But we also oversee rehabilitation services at University of Chicago, Northwestern, and many affiliates all around the state, country, and a few hospitals around the world too.
Thank you. So I'm going to start with the first question. So wearables, they're usually tracking information, but with AI, they've started to turn into predictive machines, right? So in this respective vantage points of each one of you, in rehabilitation science and in cardiology, what excites you the most about this evolution of AI, and what concerns you the most? Small questions just to start. All right, Dr. Okwuosa.
Yes, okay. So when it comes, what excites me the most about wearables, I think from a cardiac standpoint, just being able to gather data from our patients is extremely important, right? I mean, I'm sure there are a good number of you that have heard of cardiac monitors or Holter monitors. So our patients where we gather information about arrhythmias from those patients. But now, these days, it's all on our watches, right? For a lot of our patients. And it's really so cool because It used to be that in the past, I'd have to say to myself, how long can I give this patient a Holter monitor? How long can I give them a cardiac monitor to wear? Oftentimes it's about 2 weeks to a month. But what if they don't have that arrhythmia that could potentially be life-threatening for another 5 months, or another year, or another 2 years? So it's really so cool to have those wearables that I know that if there's an issue, they're gonna be able to capture it in real time, wherever they are. And I've had patients that have sent me strips of what they've downloaded from the wearables, and then I'm able to say, aha, this is what you have. This is what's been causing the problem, and then let's bring you in and do more testing. So it's been really useful from that standpoint, and I'm really excited about it. I know it's a lot of data sometimes, but actually being able to gather some useful information from the data that we get from wearables is extremely important. What do I worry about when it comes to wearables? I think sometimes just having so much data can be very overwhelming. I think not just for the patient, but for the clinicians, right? I had a patient that was sending me information every day of the information that we're downloading from their wearables. And I had to say, okay, we got to kind of figure out a way to make this work in such a way that you're not overloading my inbox with the messages that you're sending me on my chart, right? So lots of data is one issue. And I think another issue is just figuring out what's important, what's relevant, and how do we make use of what's relevant in all of the information that we're getting from these patients.
Thank you. And then
I think I echo what she says. You can split it into 3 ways, right? Diagnostics, wearables, especially cardiovascular disease and other issues, the diagnostic capability has gone up significantly. The second is monitoring. As you noticed, and we heard in the previous speakers, that not everybody lives in a big city, doesn't have access to real-time information. If you live in the rural areas, or just once you step out of the greater Chicago area, it's very hard for us to keep there's not access to hospitals or clinics that close. So monitoring disease progression, disease maintenance, is your symptoms getting worse or better? Do you need to redose your medication? Do you need to redose whatever devices you're using, like your deep brain stimulator has to be retuned? All these things before, it only happens when you go to your clinical visit. And sometimes people drive hundreds of miles to get there, and by that time, you're either too early or you're too late. And so the timing of what diagnostics happens and monitoring happens has become easier with wearables. And the other holy grail is prevention, early detection. Are you going to get Parkinson's disease or cardiac disease before you get it? Are we capturing frailty and we're preventing things? Because from a healthcare economic standpoint, which is huge for a lot of companies, CMS wants, or private insurance, it's a business. They report to their investors. They don't want to pay a lot of money. So if you can capture something before that happens, the hospitalization goes down, or the amount of money they spent on complex surgeries goes down. So they're really excited by it. But so prevention is a huge thing. So it's extremely exciting. And then same goes to companies, right? I've noticed in the last 10 years, pharma companies all invest in wearables as an outcome tool, because their traditional clinical outcome measures don't have the resolution to pick up changes. And so using wearables almost sometimes reduces their sample size and the amount of money they're spending on trials. So as big companies, I've noticed, like I've worked with Apple, Google, Amazon, Health Service, all of them invest in wearables because their technology can be studied through lesser investment in clinical trials because the wearables have a higher resolution data. And so that's very exciting. Okay, what's scary is, if you all notice, and most of you, if you're wearing a wearable, just shake your hands as you're sitting, it'll start counting steps. Or calories will start burning. You can put it on your dog's tail, it'll count calories and steps. So the algorithms are very generic. They're trained a lot of times on healthy individuals, and they're looking at simplified measures because a lot of times companies don't have the money or the time and effort to invest in large-term, high-resolution data collection. So a lot of generic accelerometry-based algorithms, which are kind of correlating with clinical diagnostic measures, allows us to over-predict or under-predict things, which are dangerous. Because that, as long as it's, I think I burnt 800 calories where I actually burn 400 when I'm running, is okay. But you don't want to give that to a person with cardiac disease or something where you're now under-predicting some kind of a symptom or a disease progression or regression, or over-predicting. Like I've read articles about how breast cancer is overdiagnosed through certain technologies. So that allows us to do a lot of things which are wasteful and also dangerous. So to be more high resolution is critical, but there's a lot of pressure from these companies to come up with information. So sometimes I feel like we're walking kind of a thin line where we're guessing to being sure about what we're doing. So we need to do a better job about that.
Thank you. So, Dr. Jayaraman, I'm going to stick with you for a second. Now let's bring generative AI into the picture. In your particular research, how do you see generative AI enhancing the precision and personalization of wearable technologies or of this data in the areas of mobility and neurological conditions?
Yeah, and pardon me if I sound very engineering or technical on this, right? Historically, when you had all this data which came out, we would do traditional engineering signal processing, and you would mine all this manually and then run it through a computer, and then we would look at it and we create these models where you would visualize it, and we're hoping there's a correlation, simpler statistics. But now with artificial intelligence, the statistical tools have just become more high resolution. Basically, we can mine through a lot more data and be more predictive and more accurate. And so our warning systems, what I feel, don't need long-term data monitoring. So to give you an example, before, if you had a wearable, we need the whole day or month of streaming of data. And then you would mine through all of that and you would make predictions. You would say, oh, somebody has neurological symptoms are getting worse, cardiac symptoms are getting worse because we looked at all. But now with just artificial intelligence, it's able to look at signatures in short-term or small pieces of data. So you don't, it's called snapshot data collection, which means you don't need months of data, you just need snapshots. What that allows is, because of artificial intelligence, it's able to look at more features within that small piece of data. Before, you would need a full signature of a behavior to make a disease prediction. Now, artificial intelligence can look at features. For example, before Parkinson's disease, right? You need to have enough tremor, rigidity, fascination of gait or movement to say, oh, somebody's Parkinson's is getting worse. Now I can do a 9-second finger nose test, take a smartphone camera, take a video of a 9-second video clip. An AI tool can look at over 1,000 features within that 9-second video clip, whereas looking at simple things like how much acceleration is my finger going towards my nose, and as it touches my nose and it comes off, what's the peak of the acceleration, the downslope of the acceleration profile, how much does my finger move within that? That's a few examples. To 996 other features, and actually can tell whether your Parkinson's symptoms are progressing or regressing. Even a trained movement disorder neurologist who's looking at that will have no clue. It'll look like this. Cannot pick up if your symptoms are going up. That's how artificial intelligence has helped us get better.
Thank you. And then a similar question for you, Dr. Akwasa. How do you see AI wearables helping identify cardiac risks in cancer patients and survivors?
Yeah, I think AI has been really, it's one of those things that now there's a lot of conversation about, right? So one of the things that I talked about earlier was how, from an oncology standpoint, you have precision oncology. From a cardiovascular standpoint, you have gathering of data from the cardiovascular imaging that we have. And combining both is going to be so relative to risk prediction. So risk prediction is one of the ways that I really think that AI is going to be useful to us. So I'll just tell you overall, you know, from a cardiac standpoint or even from a cardio-oncology standpoint, we have certain disease processes that we always have to ask ourselves, how are we going to predict that this patient is going to have a result? I'll give you an example. A patient comes in, they've received, say, doxorubicin chemotherapy for cancer. And we know that this particular cancer is going to increase the risk of heart disease or the risk of heart failure in future. Ultimate question that we're going to ask ourselves is, when is it going to, first of all, is it going to happen in this patient? Because not everybody is going to have that problem, right? So question is it going to happen in this patient? And if it is going to happen in this patient, when is it going to happen? Now, the risk of doxorubicin, increased risk of doxorubicin heart failure is something that's a lifetime risk. So this is a risk that the patient has to live with for the rest of their lives, right? Is it going to happen in 10 years? Is it going to happen in 20 years? Is it going to happen in 40 years? Is it never going to happen? And so predicting this risk is never relevant. Right now, what we do is for patients that are high risk, we tend to get echoes. And if they've received chest radiation therapy, we would get stress tests ever so often. Some people get it every 2-3 years. Some people get it every 5 years. Some patients even get it, especially those that got it in childhood, get this testing every year. Are we over-testing these patients? Could we test less? But if we can predict their risk, if we can say that we know exactly who is going to have a problem, maybe we can focus on those people that we know are going to have a problem and then test those people rather than having this generic tests for a whole bunch of people, which of course is costing the healthcare system, and you may not get as much benefit from it. On the flip side, some of these patients also go out, they finish treatment, they go out into the community, and their physicians or their primary care doctors or whomever is taking care of them in the community, especially rural communities, completely forget that these patients have received these treatments. And then they come in years later, 10 years later, 20 years later, they're in heart failure because of this drug that they received how many years ago, right? And so if we knew and we could have predicted, we would mark this patient and say, this is a patient that's at risk. And so for that reason, we want to make sure that even if they go out into the community, their doctor knows that they're going to be, they need to have these tests. And the patient will know, I need to have these tests for the rest of my lives, particularly because I'm at risk. Or maybe even better, is if we find treatments for these patients, we could put them on those treatments ahead of time, going out into the community so that we don't have to worry about those cardiovascular risks and the risk of heart failure that's present for the rest of their lives. As you all know, heart failure kills. It leads to heart transplants. And also in oncology patients, a lot of cardiologists, heart transplant cardiologists and cardiovascular surgeons are reluctant to do heart transplants in these patients because they've had cancer and we don't know if they're going to have recurrent cancer, recurrent malignancy. So again, these are all the little nuances that I feel that AI could help us in risk prediction in such a way that we can make informed decisions on managing these patients and taking care of these patients.
Thank you. Thank you. Now let's turn this a little bit on to health equity. So these AI models, right, they're trained on data. How can we ensure that there's no biases on this data, that we're serving all populations and not just focusing on the population that the AI was trained with in some, implicit bias way? How do you, in your research, consider these points to make it equitable?
Yeah, great question. If you do traditional research, and if you've all worked with the NIH or the Department of Defense, there is a certain requirement that you meet your city's racial distribution on patient enrollment for any of your studies. So if there is a certain higher population of a certain race in your city, you're supposed to meet that requirements. And in fact, sometimes we have to say 0 to Pacific Islanders, and then you have to write a whole paragraph on why you said you have recruited 0 people. So there is a national push to make sure there's equitable recruitment for research. But with wearables and artificial intelligence, the big advantage is they've gotten cheaper. Wearables have gotten cheaper and cheaper. So we offer, when we do clinical work or research work, to people all across the greater Chicagoland. And we make sure that the data is labeled in these populations, because somebody else brought it up about the melanin issue on how the tool was not being accurate because of that. So we're very aware of that. And so when we even track patients using artificial intelligence, the whole heat mapping strategy is very different depending on the race or the social equity, where they live, and their financial capabilities, right? So that's why you have to make sure your labeling of data covers all populations. And then artificial intelligence is pretty smart with new transfer learning techniques and other things. It's able to learn as long as you are able to sprinkle some signatures off the whole population. It kind of captures and recognizes, oh, the behaviors are a little different. Their physiological symptoms are a little different. So I should be very careful on my diagnostic capabilities. So that's why we believe in some kind of a semi-supervised learning rather than a complete automated learning process where it tends to bias. We kind of guide it and say, hey.
So for those that might not understand semi-supervised, supervised, so you mean semi-supervised by having a human in the loop that determines this is this population, this is that population?
Yeah, so because sometimes, a lot of times, it's more attractive to say I used a deep learning technique where the artificial intelligence is doing all the work. But the biggest difficulty with it, it's a black box technique where it's getting you the best accuracy you need rather than it doesn't take into consideration ecological aspects and social equity. So by putting a human in the loop, you make sure the artificial intelligence, for a lot of times it's pretty dumb, that it learns from that. You tell it to go and say, hey, I need you to cover this part of the city and this part and this part so that the data is equitable. Otherwise, it's going to work for a subsection of the population and that's not fair.
Great.
Yeah, I think and I agree with what he said. I think the thing about equitability of data is the training data set, right? So making sure that the training data set is equitable. You know, up until the early 1990s, a lot of research that was done in medicine was in white men, right? And then the 1990s, like you said, when the NIH finally instituted rules for applying for NIH grant, the studies or the research started to include more women, and then also started to include more people of underrepresented minorities. And so this is the problem, though. Much of the data that we have from of old is in white men. Now it's becoming more diverse, and it's something that needs to be emphasized. I sit on an advisory committee for the research advisory committee for the American Heart Association. And in the advisory committee, this was one of the things that was recommended to the people that were doing this research that we're supposed to be advising, saying it's important that we recruit more diverse population of peoples in order to complete this research. One particular institution that was involved in this research found it really difficult to recruit people from minority groups into their group because of where they were located. But because we insisted that they had to do it, they then had to go outside their comfort zone, outside their institution, to recruit minority groups from other institutions, which then made their data more diverse. And now this is the kind of data that we can use in training AI in future to identify risks, right? So I think it's important that even if we're in a location or we're in a situation where we can't make our data diverse, in research, we need to emphasize that diversity is important. Because otherwise, right now we talk about disparities in care and we talk about inequities in care and all that. It's going to get worse with AI if we're not very careful. It's going to get worse if we're not purposeful about trying to make our data sets diverse. And it's diverse with respect to age, diverse with respect to race, diverse with respect to sex, diverse with respect to disease processes or whatever it is that we're dealing with. It's really very important that we be purposeful about it for the future in order that we can use it to decrease the disparities in care.
Great, thank you. Now, okay, so we have this idea of kind of being intentional about diversity in the training data to basically reach a wider population with accuracy, right? Now, how do we put this in the hands of clinicians? Meaning, like the big question. There's EHRs, you know, in the hospitals. How do we integrate these findings so that clinicians can have quick access to that information? Because that, I mean, there's so many forces there. So
yeah,
pick one.
Yeah, I'll give you a couple of examples
Yes.
on how we're doing it. For example, you mentioned Dr. Faizan Abdullah at Loyola. So one of our projects is to use, so artificial intelligence or wearables, there's two ways to do it, right? One is to use your Apple Watch or your Fitbit and use the proprietary algorithms which are already in it. A lot of the work I do is to extract the raw data from the sensors and create custom algorithms. There's a lot of work, and you have to really like it to be involved in that kind of work. But for example, with Faizan's project, the idea is post-appendectomy or surgery after that, a lot of these children end up getting infections. And a lot of times they're detected pretty late by the caregivers, and they end up at the ER. So his whole interest is post-surgery to capture the infection much early as possible so we can warn the physicians and the surgeons and the caregivers so that it's not getting complicated, right? So just using the Fitbit data, which for all types, it's not a lot of times trained on children, but children love to wear a Fitbit watch and it looks cute on them and they're not going to reject it. We're just taking the proprietary algorithmic data and created an algorithm which warns an infection 4 days before it happens. So that way we send it to a dashboard to the surgeon and the physician team, and it's a simple warning system. Again, you can give them heart rate, sleep, activity monitoring in real time, and that's gigs and gigs of data just streaming. An everyday physician doesn't, or surgeon doesn't have time to go through that. That's too much information, it overwhelms them. Here we've just created a warning system. So all it does is a warning saying that there is a high rate for infection. So that's another example. The other thing which we use often is camera systems or wearables in the hospital rooms. Again, that's a high risk for fall again, or readmission for infection, right? We're a rehab hospital. If somebody gets an infection and then they go back into acute care, we're not going to get paid for their length of stay during that. Or if somebody has a fall in our hospital, again, insurance is not going to pay us because that fall was a hospital cost event. So using wearables or camera systems, computer vision technology, we're able to look at behaviors prior to a fall or prior to an infection occurring. So that's where artificial intelligence comes in. It gives you such deep information that you can pick it up. Somebody's about to fall, they don't just get up and fall. They've tried to go to the bathroom a few times, they're stumbling a few times. And there is a signature which visually, you'll sometimes tell your parent or your grandparents, watch it, you're tripping often, right? But artificial intelligence has a signature it can pick up and say, that's a 90% fall risk. So it's not a fall detection algorithm because there's no use picking it up after you fall. It's a pre-fall detection algorithm. That's where artificial intelligence. So these are examples where you can use existing information, simple algorithms from wearables, and then it automatically dumps into Epic or Cerner and creates a warning system and flagging system. It doesn't have to be super complicated. You don't need to stream them with data every point and freak the clinician out. You can set up simple ways to warn them.
Now, do you want to?
Yeah, I'll just say very quickly. I mean, that's exactly right. I completely agree with that. I think, even something that's working now that's similar just kind of gives an idea. I'm sure many of you know people with pacemakers or defibrillators. So from a cardiac standpoint, the pacemaker and the defibrillator, they're constantly, every minute, every second, monitoring the patient's heart rhythm every single time. But we don't get any of that data, right? But once there's an arrhythmia that is life-threatening, we get an alert. As cardiologists, the patient's cardiologists, you get an alert. I receive either a phone call or text. Well, they text and they don't reach me, they call. They want to make sure that you hear it, right? The general idea, they say this patient at this particular time had this arrhythmia, and so they expect you to do something about it. And that's really the bottom line, right? It's something similar to that. Now, we're talking about wearables and AI, but this is kind of the same sort of information. If we were to download all of the information from the defibrillator or pacemaker of the patient, it would be a huge mountain of data. What would we do with that? But just being able to alert us as the clinicians, as the cardiologists, to say there's a life-threatening arrhythmia, and then you do with it what is necessary.
Thank you. Now so we see equity, we see how we integrate this with the clinicians. Now, in terms of the patients, we go to the, think of Minority Report for those who saw the movie. This idea of predicting events, predicting clinical events on people, right? How do we maintain accountability, transparency, ethics when we're embracing innovation, when we're first early adopters of innovation? And by the way, I'm weaving in questions from the crowd. So if I didn't ask your specific question, I'm sure you can relate to some of the ones that I'm asking. But yeah, so how do we avoid the Minority Report kind of thing? Or how do we make it ethical, right?
Yes,
Predicting.
it's a great question, and it's also a loaded question, right?
Yes.
Because you don't want too much information, which will make you freak out all the time. And then once you start looking at one video, you start doom scrolling on 50 different fake interventions on Instagram or whatever you're looking at, which is going to solve that problem. My wife said, why do you always get these hair transplant videos on your Instagram? I'm like, I don't know. Maybe once I looked it up and now all I get is only that. And it's painful almost. And every time I see it, I'm like, oh God, one more. But the algorithms are pretty dumb in a way. They watch one video and they assume that's what you want and they start streaming the same nonsense to you. So that's why you don't want too much information. As she said, you want to be warned on critical things. And that's what these startups or new companies or older companies should do, is to look at long-term behaviors and warn when it's starting to get into a critical phase. And it depends on the question, right? So if you're looking at general health, then unfortunately you have to input information and it's saying you got 7,000 steps, you got 4,000 steps, you 400 calories. Now you need to eat less and eat more greens or something like that. That's a little bit allows you. In the past, it was entertaining because you got into this obsessive thing of where I'm taking care of my health. Long term, a lot of us give up on it. It's just so hard to track. So do we want to be stuck on those things? or not is a question we all have to ask. Same goes to medicine or what we use. You don't want to give too much information to the physician or the patient. They become scared, they become paranoid, they're now not enjoying life. All they do is to keep. I did a study about 5 years ago with University of Illinois where we're GPS tracking our patients. And I could see them minute by minute where they were going, and we would overlay Google Maps on where they were going. Then I started getting all kinds of creepy information about them. Because the whole idea was to look at whether they were exercising. But then now I started looking, where are they going? Why are they in the middle of the night going to this location? It just becomes too much information. Same way to us. So the government, for example, I sat on a federal government think tank where they were saying we're going to give wearables to all citizens of the United States. This is an actual bill which is trying to pass on this. They want every citizen to have a wearable. And they were going to monitor blood pressure and heart rate. And our question was, okay, what are you going to detect with this? Everybody, you can look at everybody's blood pressure and heart rate. That's not diagnostic. That's almost freaks you out. Because, okay, your heart rate goes up. What are you going to do with that? Your blood pressure goes up, go down. It's not diagnostic. It almost freaks you out. So sometimes too much information is bad information. You want to set up thresholds, and that has to be institutional and government involvement on what is that threshold. Because, don't take me wrong, companies are supposed to sell products. They're going to obviously freak you out. They'll say a 2% change in your heart rate variability means, have you seen those sleep apnea ads? Like that, you are going to die. You are 4 years from cardiac disease, 6 years from brain tumor, and you're like, what? And the guy looks very logical and is probably says a doctor, somebody, like the Huberman Show, if you listen to it, it's a lot of hype and freaks you out. And then you'll be like, I've been drinking this water and this protein shake, so that's why I'm getting better. They're just trying to sell stuff to you. So you have to be careful. As a company, yes, you need to sell, so you're gonna a little overhype it. But as an individual, you need to not make yourself paranoid. So you have to hit ethical standards, healthcare standards. That needs government, unfortunately, intervention where you set some ground rules. Right now, there are no ground rules. It's a free-for-all, so it's junk in, junk out. There's no way for you and I, even I who've been in the field long enough to know what is true and what is not. Because I get freaked out at 9 o'clock when I'm looking at that hair videos. Oh my God. I need to go check on somebody. It's similar to you guys. So there's need to be some kind of standards to be set.
Yeah, and I completely agree. I think government policy, government standards, I think that's really important. Set the standards so that, but I think it's also going to need to be nuanced, right? Because what's standard for certain fields will not be standard for other fields. So I think it has to be nuanced. I think there probably has to be things like task forces set up for each specialty or each group or each sort of research in order to be able to set standards that are specific to that particular field or that particular area to make it make sense to the people practicing it and also to the patients that are involved.
Thank you. Now, thinking of the future, what advancements of AI do you imagine, say, 5 years down the line, that might have a great impact on cardiovascular and overall population health? Let's start with you, Tachi.
Yeah,
And how do we ensure that it's equitable?
Yeah, I mean, how do we already talked about equity, which is just basically making sure that the data, garbage in, garbage out, right? But if we have great data coming in, then we're going to have great data coming out of it. I think that in 5 years, none of us, in my opinion, is going to really be able to predict much about where AI is going to be in 5 years. But the general idea, I think, for us is that we're trying to make sure that AI is able to help us assess disease better, is able to help us think through disease better. I think humans have to be somewhere in between. These days, I'm a cardiologist. I have some of my colleagues that are particularly focused on imaging, right? So cardiac MRI, cardiac CT scans, PET scans, that sort of thing. All of these, there's all this rumor out there that cardiology fellows or trainees in cardiology are really concerned about that if they go into imaging, AI is going to take over imaging. That's it. It's going to all be AI. Radiologists, there's all this concern. Radiologists, it's all going to be AI. Physician radiologists are done. In fact, I attended a talk, it must have been like 3-4 months ago, and the person that was speaker, who's actually a world-renowned speaker, said, in future, doctors and certain types of health practitioners are done. It's all going to only be people that actually physically do things with patients, like nurses and the rest of them. The rest of you that think you have a brain to think, you're done, because AI is going to take over. So I think there's a lot of all of these rumors out there about where AI is going to be in future, and everybody's really scared of it, right? I mean, you know, for a real life example, we've talked about AI and we've talked about how AI is going to take over jobs in the US. And the assurance last year, I remember, was, no, that's not going to happen. But look at what's happening. There are all these job cuts from Amazon and the rest of them, and they're cutting jobs and using AI in place of humans. So I think that there is a lot that we need to think about with respect to how much AI can do, how much humans can do. We in medicine generally feel that we need physical people, physicians, nurse practitioners, physician's assistants, there to think through the data from AI and make sense of it in such a way that it makes sense for a human. We know that AI hallucinates. We know that there's data breaches, and we know that there are problems with AI. And so we should always have humans there to ensure that the data is accurate and the data is usable and can be applied to humans. But again, companies want to make money, so we're going to need to see where all of this ends up in future. I think it's going to be hard to predict, but we'll see.
I mean, I 100% agree with her, right? So it's critical that we focus on what is known as fair AI. And that's a hard thing to do. On one side, as she mentioned, and I've mentioned many times now, companies, you have to make money. You have to be able to provide a tool which is better and better every time. People have less, what I call, like a lot of my patients, right? If I work on a certain technology, they would be super excited. Nowadays, 1 week later, they're like, I saw this on Instagram. Why am I not having that? Why are you giving me this? Because traditional clinical trial research to product to commercialization takes 10 to 15 years. Nobody's going to wait that long anymore. People want a new product, new care, new cure much faster. So AI helps to get there, but you also have to be what is known as fair AI, which means higher quality AI, better information data, which is more higher resolution, so that you're not doing AI for the sake of just making money, which is a hard thing to tell people. Don't use AI and technology just to make money, but also to be fair to ourselves. So it's a very tough boundary to draw, because you want, for the betterment of mankind or humankind, you have to be able to let AI take a good role, but without destroying everything which we built up. But at the same time, we're all kind of running a race where we want to make more money, live a higher quality of life. And we want AI or technology to give the answers to all our questions very fast, which is why we don't even know the difference between expert evidence to opinion pieces. Everybody has an opinion and just needs a camera and a mic, and they give you an update on AI. And a lot of people don't know what the difference, that's just his or her opinion. That's got nothing to do with true evidence, data. And so you're struggling with products and companies which make up stuff to people who have put in a lot of sweat and time and effort to build their product. So that's why we all need to be fair to the system, so that AI has a greater role, but it also has to be a fair role, so that we're not beating each other up.
Is there a way, so bringing in some questions from you guys, is there a way that to hold AI companies accountable for this lack of diversity, excessive prediction risks that might have been incurred in because money trumps risks, right? So is there a way that you guys can think that we could hold those companies accountable?
I mean, it's a great question, but it's a very tough question, right? And I'll tell you, I work in robotics too. There are certain countries who have invested hundreds of billions on humanoid robots. But they say it's for healthcare. I highly doubt it. But if we don't do it, you're going to be left behind. So that's the same problem. We can set up ethical boundaries by government and other societies for doing safe AI work and equitable AI, but then you're competing in an open market where somebody's probably made people work 4 shifts nonstop and is bending all kinds of rules to get their algorithm developed, and now you're competing with that. We find that every day in our field. And so it's a very catch-22 situation. Do you want to compete or left behind? And you keep standards, or is it all open to all and we're going to fight with bare knuckles? So that is something as a country we have to decide what standards we set, because it's very difficult in an open market to compete otherwise. You're going to get beat up pretty fast.
Which then leads to a slippery slope, in my opinion. So we will, again, have to see how all this plays out.
Excellent. So one last question. Again, it's bringing from the audience, but I'm putting my own thing there. Hopefully, whoever asked the question will like the enhanced question. So can you name one thing, coming into the field of AI, can you name one thing that you thought you knew and then you were wrong about? In other words, maybe misconceptions or maybe the way you research with this.
Yeah, for example, I thought when I started using ChatGPT that somebody's uploaded all the information for all topics automatically. So when I asked it to help me, that it was going to give me great answers. Horrible answers to a lot of questions, completely wrong. It actually gave my paper to me saying to read it once, and things like that. So the algorithms are still pretty bad. So a lot of times we're trusting it so much for so many things, so we need to be careful. That goes to Gemini and Perplexity and everything we use, but we're in a sense of hurry, constantly catching up, so we tend to believe these things. And now there are new software tools to pick it up. So I'm just saying, just be careful. That's something even I, who have worked in the field, assumed it's really smart because I paid for the business version of it. So I thought, okay, maybe they're going to give me a better version. It's not true. Even that sucked big time.
Yeah, I think similarly, if you're writing medical papers and you want to have AI help you, at least for me, pull out references, sometimes those references are wrong. And so I'm learning that I have to go in and actually look at the references just to make sure that the references are accurate. I also learned that I can challenge AI, right? That's the beauty of it, is I can challenge AI and say, this is not right. I want you to think about this way. And it would usually apologize and then go about and do what you asked it to do, which is interesting. So, I think one of the ways I've learned to use AI is not just learning to type in questions and have it give me back answers, but to challenge it and have it challenge me back. So that way it's kind of like we're kind of working together, like almost like I'm working with my assistant to help then make whatever it is that I was going to do more robust rather than more linear.
Thank you. Well, it's 11:58, so I think with this we will conclude the panel. And let's thank Dr. Okwosa and Dr. Jayaraman for this. Thank you.
That was really dynamic and very energizing around what's on the ground right now and how it really ties into real-world clinical decision-making. For me, I just was reflecting, it just sort of underscores the humanistic lens that's necessary, not just the data side of things, and that the critical reflective thinking is so important, whether it's thinking about data at the right level of information for decision-making or thinking about the data in, equity consideration starts from the data, not just the analysis and application. And then as you were talking at the end around the human part of, we're trying to influence human behavior, and that's trust. That's credible. Do I believe in the person that's trying to influence? And I think we're going to be learning more and more about whether or not we believe AI bots or engines, and we're in a real world evolving area right that. So it's almost like whether it's a Wild West or what have you, but this is the environment I think that's exciting. I do work in FDA regulation, and so this is the world in which things get broken, and that's how you get regulation. So we should be ready that there are going to be things that don't work, and that's going to teach us, and that's usually what motivates humans to put in standards unfortunately, when something happens. So you really have inspired us to think in a lot of different ways as being good consumers of the information. So I want to thank a well-moderated panel. Again, the third panel is focused on health and data in real time. It's going to be led by Dr. Karen Sabin, who is an endowed chair for research in our School of Nursing at Loyola University Chicago, and we look forward to our panel discussion. Thank you.
Much.
Welcome to the next session. So this session is going to focus on health in real time and how wearables can be used, or technology can be used, to help be more proactive in preventing health rather than reactive. So I'm going to go ahead and let the panelists introduce themselves.
Hi there. My name is Dr. Ilya Karagodin. I'm a general cardiologist, and my role at Endeavor Health is the Director of AI and Advanced Analytics. I'm really excited and happy to be here. Thank you for having me.
Good afternoon, everyone. My name is Steph Wilding, and I'm the CEO of Community Health. Community Health is the nation's largest volunteer-based free health center. We provide primary care, over 20 different specialty care services, behavioral health, dental care, and we have a full pharmacy for our patients, all free of charge.
My name is Chet Robinson. I was asked to be here. Previously, I was the Chief Medical Officer for Walgreens Boots Alliance. I worked a lot in the innovation area. I'm also, second hat that I wear is as a board member for the American Heart Association here in Chicago.
Thank you so much. So this first question is for all of you. You're welcome to respond. So wearables are giving clinicians and patients more real-time insight more than ever. How close do you think we are to using these tools proactively rather than reactively?
Happy to. I think we're there. I can say that with my patients, many of them carry these wearables around on vacation, on a day-to-day basis, and they're constantly sending me their data, whether it's their heart rate or their rhythm, and asking me for active feedback. I think on a more kind of personal level, myself and many friends of mine use our wearables to kind of motivate ourselves. And actually, Dr. Robson and I were just talking outside about how, when we've been sitting for a long period of time and the watch tells us to get up and move and to stand, I think that's a motivating factor, certainly for me. And so I think we've reached the proactive era of wearables.
If I could just add to that a little bit, and it made me chuckle because my ring was telling me to stand up and stretch earlier. I feel like it's very gentle in its nudges. I would agree with that. For folks who have access to the wearables, I think we're at the point where this can be more proactive. I think when we look at the arch of innovation adoption here, we still have a number of populations, and I know there was a session on equity earlier in the day that have some barriers to adoption. And so I think for those who have adopted it, we're there, and we still have more opportunity for under-resourced communities.
Yeah, I very much agree with that, and I think it depends on how we define what the equity is and what those populations are. I have two examples that have happened to me. One was quite a long time ago when my admin was a marathon runner, and the cardiac monitors where you could do them on your phone and put your fingers on it, and it would give you this miniature EKG. So we were all excited, and so we're testing everybody. We're running around the office testing everybody. And her EKG showed that her heart rate was well over 100. We go, well, maybe something's wrong with the device. We'll check it tomorrow. We check it the next day. No, and she's running like marathons, about one a month. So still high. So I said, well, you should probably go get this checked out, right? Directional. Right, and lo and behold, she had a thyroid disease that was treated, and she was able to address it. The other one that was really striking to me, being from a pharmacy, is we had prescribed. We had a program where people had a question about medicine, they could call a pharmacist from anywhere, anytime. So we had a person out in the Seattle area that had bought an altitude sickness medicine and was up climbing Mount Rainier. He was partly way up Mount Rainier and all of a sudden realized that he had forgotten to take the medicine, and he got an alert on some monitor that said, you're at an altitude, you might consider this. And he was like, oh, well, should I take it now? Should I not take it now? What should I do? A similar situation to many of us have every day. my child's had a fever for 4 hours. Should I do something? We were talking earlier, making those decisions. When should I go to see the doctor? When should I go to the emergency room, right? So from the side of Mount Rainier, he was able to call the pharmacist and get the information about what to do. Being able to monitor something that in any situation, whatever activity that you're involved in, I think there's tremendous opportunity to help people in a lot of ways.
Absolutely. So this question is for you, Dr. Karagodin. So your work applies to AI and analytics in echocardiography. How are you seeing wearable data and imaging data come together to predict cardiovascular disease more accurately?
Thank you for that question. I think both pieces of data are part of a bigger puzzle, and I think it's important to integrate these multiple data streams. So, one of my sort of areas of focus is reading echocardiograms or echocardiography, and that gives a good amount of data about the structure and function of the heart. But that data in and of itself cannot necessarily predict risk of cardiovascular disease. You really have to integrate that with things like vital signs, which you can get from wearables, things like labs, patient history, family history, genetics, right? So a growing area in our field is genomics and things like polygenic risk scores. And we have some data and some literature that shows that when you combine all these different data streams, you actually increase your degree of accuracy in predicting cardiovascular risk. There's some data out of the UK Biobank that when you combine all of these different data streams with wearables, you can actually increase your area under the curve to detect cardiovascular disease. And so I think we're just entering the era where we can integrate all of these streams, put them into a machine learning model, and increase our degree of accuracy at predicting cardiovascular disease. So very exciting time, and I think you got to take all the pieces of the puzzle together.
Thank you so much. So this next question is for Dr. Robeson. So having led a digital innovation at Walgreens and now advising emerging health tech companies, what lessons have you learned about scaling these wearable technologies?
Yeah, thank you for that question. So what I'm going to talk to you about is an outcome of learning, because I started at Walgreens about the same week they discovered that there was a problem with Theranos. So my department was challenged with, once we got over that, right, how is it never going to happen again? We need you to put together a program so this never happens again. So we put together an evidence-based review process that we reviewed every product, every digital innovation that came through, or anything that came through. But we also used it as a tool to be able to build things and grow things and so forth. And there were kind of 4 primary pieces of this. The first one was knowing specifically what the population was. We talked a little bit about that, is that there's a tendency to look at the common things, race, ethnicity, and so forth. But you have to really think almost like an actuary of thinking, what is also the age, what's the gender, what's the geography, right? Because a lot of times actually health-related equity is a much bigger challenge than some of the other areas. And then you have to think about specifically what problem are you trying to solve? Because we would get people that would come and say, like, we could do anybody and we can solve 16 different problems. My guess is you probably can't. So it's be very specific about what problem is being solved. The second part then is, how are you going to do it? Are you using a ring? Are you something on the wrist? Do you have, some kind of a gel that they put on? I mean, there's a zillion different ways this data can be collected. How are you going to do that? And the people that you're going to do this with, can they do that? Can they wear a ring? Do they want to wear a band, right? Are they ambulatory? Are they, all of those factors, you have to be thinking through exactly how you're going to do it. How are you going to incentivize them, right? these alarms that, when you go into atrial fibrillation, really, really, really important. But how do you give a trend so that over 2 years we see there's a gradual change in your heart failure? There's a gradual change in your hypertension. How do you use these things to have long cycles and not just immediate cycles? The third area then was cost, right? Who's going to pay for it? What's the value chain of this? How is this financially beneficial for you? One of the speakers earlier was an investor. She spoke some about this. Who's going to make the money from this? And then how do you make it available to people? Because it's not only the cost of the device, most of them now have a subscription. Who's going to pay for the subscription? Is it tied into some other kind of a program, right? And then where is this data going to go? Just to the patient, to the doctor, to where does this data go and how can you utilize it? And then finally, what is the regulation about this? Is it FDA approved? Does it have a CE mark, right? What are all of the basic requirements to make sure that the data stays secure, that you're also able then to take this data and the final thing was, does it actually make a difference? Can you have any studies that say that by using this, that their diabetes improved over a year, that their heart failure was better controlled, that they had over time any kind of a marker that shows that this made a difference? It matters partly because obviously for the health of the patient, right? It matters because someone's going to pay for this. And if you can't demonstrate that even though it's the coolest technology in the world, right? And that 8 million people have this device, if it hasn't made any difference, I hate to say it by name, but early that was called kind of the Fitbit experience. Is that all of a sudden everybody bought a Fitbit and they started walking 10,000 steps a day for about 2 weeks and then they went, now what do I do? What does this mean, right? It's the same thing. If you want people to pay for it, an insurance company, a patient, the health system, anyone, you have to demonstrate that there's outcomes.
I totally agree. That is so key. And as a researcher, I'm very interested in outcomes. So thank you for that. So this next question is for Steph. From a community health perspective, how can we ensure that the benefits of wearables extend to patients who are often left out of that innovation due to access, connectivity, or comfort with the technology?
Yeah, absolutely. I appreciate that question. I think when we're thinking through this, it helps to level set. What are the key barriers for example, the patient population at community health when it comes to adopting wearables? The first is just the cost of the device. That's first and foremost. We're looking at access. The second is around connectivity and data. Most of our patients access their data through a limited package on their smartphone. That's how they have the internet. Which means, for example, when we've had to adopt telehealth, a patient might schedule a telehealth video appointment on the first of the month, but it's at the end of the month, and by then they're out of their data and they can no longer do that video appointment. Just to give you some specific, examples of that. I think another is around, certainly data literacy, tech literacy, and then the fourth I would say is around understanding what folks are doing with this information. For our patient population at community health, it's a heavy immigrant population. And we are getting a lot of questions right now about where does our EMR data go? How are we sharing that? Who are we sharing that with? So that would really extend to that as well. So those are the really key barriers. And I think some of the solutions to that is, obviously access is how can we have innovative funding strategies to get these devices in the hands of folks? Through innovative partnerships, those sorts of things. For data and connectivity, we either need offline options or we need that innovative partnership that's going to fund that data. When it comes to the adoption of the technology itself, as well as the comfort with the data collection and surveillance, to me, this is really where key trusted messengers are needed, community health workers, navigators, even our clinicians. These are trusted messengers that can partner with our patients to help them understand how to adopt this information, what to do with it, to your point, and also helping them to understand from a transparency perspective, where's this information going and how safe is it for them?
Thank you so much. And I think that was talked about earlier was this importance of trust, I think that is so critical. So this next question, I think anyone can answer. So many chronic conditions like hypertension, diabetes, heart disease develop silently. So how can wearables help flag these early warning signs in a way that people can make some changes in their health behavior?
I can address that one. So, I think we get a wealth of information from these wearables, everything from heart rate trends, blood pressure trends, sleep patterns, even more specific things like heart rate variability. And, I can speak from talking with people who use these wearables that as well as myself, frankly, that it's very motivating when your watch tells you, oh, you've gotten less sleep last night, or you've gotten less, your heart rate variability went down. Maybe you're under more stress, that sort of thing. And so I think these constant reminders that you could do a little bit better, or perhaps, you're under more stress than before. I mean, these are actionable items, right? So we're all, we all respond to rewards and incentives, right? We're all human. And so it's almost like when you gamify the wearable, it makes it more motivating. And so, when you have a device telling you, well, you haven't quite reached your goal, or your heart rate variability has gone down, you might be under more stress, I think it motivates you as an individual to do better. And so, that cuts across all socioeconomic statuses, et cetera. But of course, as Stephanie mentioned, access is still going to be key, and that's a barrier that we'll need to address before this becomes totally mainstream.
Any other comments?
Yeah, I would say one of the things I love about this panel is that we represent different sectors of health delivery, right? And the audience, yesterday I met some nursing students, there's people in industry, finance, hospitals. To me, the biggest thing that these do is they give all of us the opportunity to help educate people who have questions about their health care. Because all of a sudden, your grandpa's saying, this thing says my heart rate's, what should I do? Right? Somebody is asking you a question, and everyone in here, everyone's listening, is in some way a healthcare provider in different ways, and at least can say, well, I know this much, but I know somebody who knows this much, right? Because what these do is they create data. They create, I should do something about this, I think. What should I do? Well, it can't always be, well, you need to go talk to your doctor. Oh my gosh, there's not enough doctors in the world to answer all those questions. What it is that every one of us can help to educate, and it can help to give some direction to what this information's about.
Yeah, I don't think I have anything to add. When you asked that question, it actually reminded me of a story. I don't know how many people in the room are Peloton fans. I'm a huge Peloton fan.
You have to talk.
Okay, great. And one of their producers was wearing an Apple Watch, and one day got this alert of basically told her to go to the hospital, and she was rushed into heart surgery and things like that. And so that's a story that has always stuck with me, and the opportunity that we have to, not from a necessarily prevention perspective, but from an intervention perspective, if we can get these in the hands of everyone and have that literacy, both data and health, that it has some truly life-saving opportunity.
And we know from things like the Apple Heart study that when the watch identifies an irregular rhythm, 80% of the time or more, that really represents atrial fibrillation. And so, that's an actionable item, and that means call your doctor or go get evaluated. And that can be the difference between preventing a stroke and an unfortunate event like a stroke or a heart attack. So it really is a game changer to have these wearables.
Thank you so much. So this next question is open to anyone who would like to answer. So partnerships are key to scaling impact. So what types of collaborations between technology companies, providers, payers, and public health organizations are most promising in advancing this proactive care?
I could actually chime in on one example that I have from community health. So we are currently partnering with Wellness West, which is an organization that's really bringing together healthcare providers, community-based organizations, et cetera, to improve the health and wellness on the West Side. And through this partnership, we've been able to have access and partnership with CareMind Doctor. DR, I think I'm saying that right. But what that has allowed us to do is for a subset of our hypertensive patients, we've been able to give them wearables, give them the data that they need. We also deployed these through our care coordinators, who were those trusted messengers who helped our patients to understand what this was, how to use it. They can go to our care coordinators for their questions, help them understand what we're doing with the information, complete transparency. We even share the dashboards with our patients. And what we've seen with that subset of our hypertensive population is that their disease is under control more than our other patients. And that's an example where Wellness West, which is really, they're sort of operating like a payer in some ways, is partnering with community organizations like ours to get the patient the access, the data, the trust, and the understanding of how that data is being used. And it's been incredibly successful so far.
Thank you. Thank you.
I would answer this in two ways. First of all, putting on my American Heart Association hat, one of the things I love about the American Heart Association is it kind of does two really big things. One is it supports all the scientific research and helps to really push the boundaries of what the evidence is. But the second thing they do is they take that evidence and then they make it so that it's education materials for the everyday person. The living element 8 and some of those kinds of things. They've started a venture fund to help some of the companies that are developing some of these things be able to come up. They have social impact funds so they can go into communities and help the businesses in those communities to begin to thrive and build up. And the third thing that they do is they really focus on all of the aspects of cardiovascular care. Because yes, it's the heart, and yes, it's the vascularity, but it's also the mental aspect of it. It's also, the employer aspect of it. There's multiple aspects that end up affecting cardiovascular health. So one is the American Heart Association, and I would urge you, if you've not been involved, that there's so many great ways to become involved. The second way that actually Ilya and I talked about a little bit before, now this is pie in the sky, but I think it's possible, is that if you can imagine, one of the things that's always difficult for a physician is they don't really have a way to gamify. They don't really have a way to reward you. So if you come back and say, doctor, look at my cholesterol went from 400 to 180, and they go, great, good for you. Now come back in 3 months and we'll check it again and see if it's still the same. And that's it, right? Imagine if the doctor was able to say, that's really cool. And you could go to Walgreens or CVS, and they have a $15 gift certificate for you, and your payer will reduce the premium by 3%, so your insurance is not quite as expensive. Now you have all of the mechanisms of providing rewards, of providing support. You're beginning to take these circles and make a Venn diagram that has positive reinforcement for what the doctor is already working with you to achieve. So that would be, I think, there's some tremendous opportunities, especially in the community, setting, to be able to, even on small ways, it can make a huge difference.
Just one more small point on the topic of partnerships. It turns out it's a small world. So first of all, I just want to say the service that community health, Stephanie offers to the community is incredible. When I was a medical student at Feinberg downtown, I was actually one of the clinic coordinators at Community Health, and I helped coordinate the psychiatry clinic of all the different specialties. And it's really an incredible partnership between, and it's not just the Feinberg School of Medicine. I think it's the UIC students come there as well.
We work with 16 different medical education and residency training programs.
It's incredible, and the partnership is real, and the students are excited to come. They volunteer on a weekly basis to come, even during exam season. And it's good for the patients because they're being seen by very enthusiastic and motivated medical students who are at the top of their game in terms of evidence-based medicine. And it's good for the students because they're learning and they're getting earlier interaction with patients than they would get otherwise. And I think that the patients are getting true evidence-based medicine on a daily basis. And that's a partnership between academic medicine and community health that I think is unparalleled in Chicago, and it's a phenomenal service you offer to the community.
Thank you. I appreciate that shout out.
Fantastic. So switching gears a little bit. So data privacy and ownership, as we talked about even earlier in the panels, are ongoing concerns. So who should ultimately own that wearable data? The patient, the provider, the company? And how do we create systems that protect privacy while still engaging researchers and innovation? It's a big question.
Well, I can tell you, we had to deal with that obviously a lot. The company dealt with medication information and a number of areas of information as to who can receive that and not receive it. And there's obviously some laws about how that has to happen. I think the bigger thing though is that the companies have to be extremely transparent about where it's going, right? They have to always make sure that they're informing patients when that data is being sold. Even though it's de-identified, the data is still being sold in some instances. And we've seen recently a couple of especially in the genetics area, companies that were selling that data who didn't really fully disclose to the populations as that's what was going on. They were making a whole lot of money, and all of a sudden people went, wait a minute, why are you making money off of my information? So I think the biggest thing is the transparency and the providing people the choice to be able to choose what they do, be involved or not involved.
Yeah, absolutely. And that certainly seems like a piece of that whole trust piece that we talked about earlier. Yeah, so. Okay. So for clinicians, integrating wearable data into care plans can be both an opportunity and a burden. And I think we talked a little bit about this earlier. So what needs to change in clinical workflows, reimbursement, policy to make these tools more sustainable and useful in daily practice?
Yeah, I think it's certainly more of an opportunity than a challenge. I think, integrating it into the EMR is key. So having a separate panel with wearable data, just like you have a panel for labs and you have a panel for vital signs, and having kind of a wearables data. And, it needs to be simple, easy to access, and it can't just be messy data, right? Because a lot of the data we get from wearables is very messy. Somebody's on a run and you get something that looks irregular, but they're just, running hard, or maybe moving a lot. And so, first of all, the device companies need to be able to sort of clean up the data before sending it over, and then there need to be secure and safe ways of sending it to the EMR and integrating with the patient's chart. So I would say that seamless integration is key.
Yeah, I'd echo that. The seamless integration, and if you have that panel, that it's not just a stream of data, that there's something actionable and clear. When I think about the opportunity that lies there, all I can imagine hearing is my providers asking me, how many clicks is this going to take, right? And so how can we make it as few clicks as possible? I think I would also add a little bit about the liability piece as well. When we have this sort of self-reported data that comes in at all times, when data arrives that's alarming or concerning, our provider's not checking that at 3 in the morning when that comes through. And so, where does the liability fall on that? And I don't necessarily have the answer, but I think that's a question that needs to be explored for the ease and trust of the providers as well.
Absolutely.
Yeah, I think the keynote speakers spoke some about that, what Apple's approach to that is. And the people spoke about AI. I actually think some of the bigger opportunity is more to rely upon, shouldn't rely upon, to utilize AI to help to give some directional insights, to give people some idea of what is this beginning to show me? Because it gets really overwhelming very quickly. By the time you get your heart rate, your blood pressure, your HVR, your sleep data, right? I have a friend who he has 8 different devices that monitor things, right? And quite often he finds that the sleep data, of course, what his bed tells him is different than what his watch tells him, it's different than what his ring tells him, right? So all of a sudden this data is like, to Ilya's point, it's like, what do you even do with all of this? And I think that is a role that AI can begin to sort some of that out, provide some insights into what's being taken in.
And I also think, prioritizing that data and knowing, this is really important. We have to go to the ER or call 911, and this can wait till Monday to let my doctor know. And I think that's hard to sort through, especially, if you're not a clinician, right? So this next question is also for anyone who'd like to respond. So looking ahead, what breakthrough technological, clinical, or cultural would accelerate the shift to proactive, real-time health management through wearables?
Yeah, I can kick us off on the equity issue, which I know, again, was earlier. But I think what we need to ensure is that when we're looking at our patient population, that everyone has access to these wearables and that we're addressing that. I think one thing we haven't necessarily touched on, but I think is just important for our underinsured folks, so people who are primarily on Medicaid, how is this reimbursable, right? We know you can do the wearable, you can have the data, but there's clinical time related to analyzing that data, meeting with the patient. How is that being reimbursed? And to agree, how is it being incentivized for the patient? And I think, those key structural changes are really necessary when we're looking at under-resourced populations.
Yeah, I actually think the greatest advancement isn't the technology. I think the greatest advancement is the people. It's healthcare workers, it's community members, it's each other helping each other to understand it, to decide how it's going to be used, when it's going to be used, right? I think the real opportunity is us as a healthcare community, meaning in the very broadest sense, working together to help to make sense of this information so that people feel empowered to understand better what's going on.
Yeah, I agree with both my fellow panelists. I think access is the key issue, and that's what we're all here to address. And I think the way, one of the ways to do that is to prove that this actually works. So to Chet's point earlier, showing hard outcomes that this can in fact improve somebody's diabetes or decrease the risk of hypertension, that can convince payers like Medicaid or Medicare to cover these more widely. And then we can make these more available to the community. And in addition to that, and I think Stephanie can speak more to this than me, but just partnerships with organizations like Community Health, whether it's with academic medicine or with big companies, so that they can perhaps donate wearables, or maybe they have a surplus on wearables, various initiatives to get these out to the community.
Thank you so much. So I'm looking at some of the questions that are coming in from the audience. So one of the questions is how do you prevent real-time data from becoming real-time burnout for clinicians? I think that's great the way they phrase that.
I don't have the answer to this, but this reminds me why I had to quit Duolingo, because it was just like, it was too much. They gamified it, and I was very overwhelmed and burnt out by it.
I think it's a really interesting question, because I think one of the challenges in cardiovascular disease especially is it's pretty easy to identify AFib. It's easy to identify an instant change. What's more difficult is to identify changes in chronic diseases over time, right? How do you manage hypertension, for the next 45 years, right? You go in, the doctor says, you have hypertension, you can diet and exercise, okay, you've done that for 3 months, it's not working, here's your pill, away we go, right? And from now until the day you die, you're gonna take that pill. Well, So what's the motivation, right? And what's my monitor going to be showing? And why would I ever want to look at it? Because all it's going to tell me is when I'm not doing something right. So a lot of it, I think, Yulia is talking about gamification, is figuring out what are ways over long periods of time you can continue to inspire, motivate, reward people so that management becomes more manageable.
Yeah, I think the other thing relates to something you said earlier, Chet, which is around the information that's provided. If it's just information, I feel like it just becomes overwhelming. And to some of the other panelists' points, which is the most important information? And so what Chet had mentioned earlier is the directional components. It's the so what. We all know that you can gather all the data in the world, but so what? What does it mean? What should I be doing with this? I think that can help to prevent the burnout, and then you add in the gamification piece, and I think that could be helpful.
Yeah, and perhaps incentives too, like you mentioned earlier. Yeah, thank you so much. So we have some more questions. One question is how can we close the regulatory gap to protect real-time wearable data for worker safety from punitive employment actions against vulnerable populations? I guess it really has to do with who owns it, who sees that data, right?
I would answer it this way. So that's been a question that has been asked for a long time about genetic information. Should you be able to give genetic information to the insurance provider because they're going to change, perhaps, if they know that you have high propensity towards Alzheimer's disease, well, they're going to change what they charge you. So for a very long time, we've had laws in place that only allow genetic data to be utilized by certain people for certain reasons. I think in this situation, it could be very much the same. There needs to be regulations that say what data can be used by whom for what reasons so that it helps to protect the person who's collecting that.
And I think at the end of the day, the patient owns their own data, 100% of the time. And so they should be empowered to decide when to share that data, with whom to share that data, and there should be a secure way of doing that. I've heard people mention scanning QR codes or even fingerprints, things like that, just to make sure that the data is secure and it's not leaving the patient's chart in any way, shape, or form.
Thank you so much. So this next question is, access doesn't always equal engagement. How would you strategize to improve patient engagement, assuming patient has access to a remote monitoring device?
Well, I think I can kick this off. I think it starts with that foundation element of having a trusted messenger who's with that patient to help them understand what's in this for me. And what do I do with this? How do I use this? Why am I using this? And that, to me, if you start off with that strong foundation with a trusted messenger, helping the patient in person to understand what engagement looks like and why that's important, and then you can add in some of these other things we've mentioned already about gamification, incentivizing, those sorts of things.
Yeah, it's interesting because when we started our program at Walgreens very early on, the devices were just brand new coming out. And we just kind of launched it and said, let's see what happens. And the thing that happened almost right away, two things. One is that to a certain extent, people just like to see internally what they're doing. So we were amazed. All we had was a dashboard and it would show you did you connect? How many steps did you take? What's the trend of it? And all of a sudden we had literally 35,000 people just in 2 days. So part of it is if you just simply begin to provide an opportunity for people to see their data, engage with it, and know something about it. The second thing, of course, is rewards. There's some benefit to doing that. Well, I'll stop there.
Well, I'll also add an example, and this isn't necessarily related to wearables, but County Care here in Cook County, as a payer, they incentivize their patients when they get their annual exams, their mammograms, they get gift cards, they get things like that. And they have found that to be highly effective for folks engaging in that preventive care. So I think we've got some evidence that those rewards do work.
just a point on trusted messengers. I think having messengers and even providers or physicians, nurse practitioners who speak the same language as the patient is extremely key. Certainly for the population at community health, being able to speak to the patients in their native language is huge. In my clinic, I happen to be a native Russian speaker, and so being able to speak to my patients in their native language and also just speak their cultural language as well. It goes such a long way, and it builds trust. So, again, whether it's through an interpreter or more ideally through a bilingual provider, it goes a long way in building trust with your patient.
The other thing I was reminded of, we did a study. It was not really cardiovascular, but we needed to recruit a number of men for a study about PSA. And so you talked about how important it is to do this, and you need to do that, right? We had like 2 guys that showed up. So then we decided, instead of focusing on why this is good for them, we're going to talk about why this is good for their grandchildren, so that they would be able to be around, to have time. And all of a sudden, we fill up the study, right? So a lot of it has to do, of course, with behavioral psychology. And what is the biggest motivator?
What's in it for me?
Populace?
Yeah,
Yes.
absolutely.
Yeah, and the messaging, right? How it gets messaged. Okay, so we have another question. It's given that baseline health literacy and scientific understanding in the general public is challenging, right? And so how do we harness AI to access this and help people understand what it's telling them and what those potential benefits are?
Yeah, I think we're seeing this a lot now. So I know like Aura has an entire insight section that uses AI to assemble a whole bunch of data. Apple demonstrated this morning, some of that AI capability of assembling tremendous amounts of data. So I think this actually is kind of the new frontier, especially on the consumer front, is having AI to create insights rather than just information, to really tell you what this affects. And not only just specifically what does it affect like as far as your heart, but it's starting to extend into mood, and it's starting to extend into all the other related areas that you can, as a person, you can feel. How do I feel today? We think a lot about how we feel all the time. And we have high cholesterol, you don't feel any different, right? We have high blood pressure, you don't really feel any different unless it's horrendously high, right? So we tend to equate disease with how we feel. So all of these conditions that you don't really feel, they always call them silent killers. But the truth is, what this wearable begins to do is it helps you begin to equate what the data is and how you feel together in ways that begin then to make sense to you.
And I think this is also a reason why AI will never truly replace clinicians. It'll make us better clinicians and better providers with access to more data. But at the end of the day, you still have to sit with the patient, explain to them what their condition or diagnosis is, what the implications are, and also address the emotional toll of that diagnosis. So again, I know people are pushing for robo clinics and AI clinics. I don't think it's going to happen. I think it just makes us better clinicians and better providers, and we still have to be human and take care of the patient.
That's so important, for sure. So this next question is, they're asking, what do you think is the biggest barrier to integrating this real-time data across providers, payers, and community settings? So some barriers.
Coming from the retail world, to me, always the barrier, the number one barrier is always money. It's the value chain of who's going to pay for this, who's going to benefit from it, where do you want to focus the money. So the greatest barrier is figuring out a financially beneficial pathway to make this work.
Yeah, I think, I mean, access has been sort of stated over and over again, and I think that's a major barrier, but I'll touch on another one that I've witnessed in my role at Endeavor Health is, just the sort of the process of getting some of these devices and wearables through the regulatory cycle and, just addressing the privacy issues and the ability to integrate these in a HIPAA compliant way. It can take 6 months, a year to get these through the pipeline. And so I think we, as a sort of healthcare industry, need to figure out a more seamless way to integrate these technologies. And we need to kind of think outside the box, whether it's secure, de-identified clouds, whatever it may be, to come up with a more seamless way of integrating data. Because right now it's still a long slog to get these technologies approved, whether it's wearables or really any new AI tool. We're still a ways away from that being a quick process. So.
Anything else? No? So this next question is how can we ensure that hospitals and clinics, including universities, follow policies to prevent biases and misinformation about patients? It's kind of a tough question.
I think it's a tough question, and when I think about that, I think about my own sleep data that I have on my ring, and it's like, shout out to the middle-aged women in the audience, right? Like, I never get a good score, right? But I'm also built different. I'm in middle age. I'm experiencing changes, and so to me, that's a bias that I experience in my own wearable experience, but I don't know what the answer is to that either.
Yeah.
I think that's a really great point, because biases are not necessarily a bad thing. It's something that we need to delve into to understand what is the bias, why is it there, how can we address it, does that have meaning in other dimensions? So, I mean, I think it helps, again, it helps to open the dialogue, hopefully.
Yeah, and AI data is only as good as the data it was trained on, right? So if you feed it data from one subset of the population, it's not going to apply to the broader community. And so again, it goes back to access, it goes back to training the model on a diverse population so that it can extrapolate to the entire population and not just a subset.
Thank you so much. So this next question is how can real-time data tools be designed to capture and respond to social determinants like housing and food security in community health settings?
Well, I love that question. Yeah, I don't know. I think that there's opportunities around, there's certain apps where you can enter factors that you are experiencing that may influence some of the data that's being collected. I think that's one solution. But I think when I'm thinking about the population we serve at Community Health, I wouldn't envision that one of our patients would know to enter that, right? And so perhaps there's opportunity in this interoperability between the EMR systems and the wearables, because we do SDOH screening on all of our patients. And so how does that connect in with the data from the wearable and to help our clinicians to make decisions and also our care coordinators to make those connections that those patients might need?
Yeah, now my mind is reeling with the possibility of a study, because I can imagine that, if you had the population, because we've talked about like the health learning difference, health literacy, and obviously if there's changes in weight, perhaps now the nutrition is not there. Perhaps as you're seeing changes in heart rate, I think it would be interesting to be able to look at a number of those parameters to say, and then put it together with some of the known or reported social determinants of health issues to say, are there correlations that we begin to see that over time, when either there's inadequate food or whatever, that we're beginning to see these kinds of physiological changes that we can put together. The other one that I saw was slightly different, but along these lines, there was an insurance company actually a few years ago that did something called geospotting. So they would take their cardiovascular patients, especially their diabetics, and they started looking at the zip code, very specific zip code of each of those, and they found that certain populations based on age, gender, disease type tended to be grouped together in certain areas, and it allowed them to be able to put resources in those areas. So I think of that, from a community support standpoint, if we were able to collect some of that data, I'll say passively, then it would allow to be able to focus the things much more specifically.
I can actually give an example of, I think, what Chet just suggested that we've been using in our emergency rooms at Endeavor Health. So over the last few years, we've developed a tool. It's a natural language processing tool that identifies social determinants of health and high-risk individuals. So people who are suffering from hunger or homelessness or whatever it may be. And what it does is it searches the whole EMR for that patient, and it flags patients who are at risk, so that if they, when they show up in the emergency room, we get an alert that says this patient is at high risk of whatever it is, food insecurity or homelessness. And so that triggers a social work consult. It triggers a social worker to come and see that patient and address those social determinants of health. So, that's something we've done, and it's actually been quite an effective tool for us.
Very interesting. Thank you. So this next question kind of goes along with this. So how can communities own their data so that they can determine how they should prioritize how they improve their community's health? Which I think is, yeah.
I'm not sure I have that exact answer when it comes to wearables, but I think I can provide an example of something that was really effective during the pandemic, that was community-led. During the pandemic, Belmont-Cragen was one of the hardest neighborhoods in the city of Chicago hit by the pandemic. And they were heavily, heavily organized, utilizing community health workers to go block by block. We were using census tract data to go block by block to identify not only who's been tested, who's positive, negative, but then during vaccine rollout specifically. And it was really a coalition of health providers, community health workers, community-based organizations. We met every Friday at 3 o'clock for 2 hours and really used this census tract data. Obviously, that was a huge person power lift, but I think that whenever we're talking about community leading itself, we want to make sure that we've got that proximity and the participation of the community. And that was a really great example of one of the ways that we did that during the pandemic in Belmont-Cragen in particular.
It's a great example. I'm also thinking too about communities who maybe are exposed to different environmental factors such as pollution, lead in the water, and how we could use those wearables to pick up on some of those changes in these communities early on.
And I think that also goes back to where does the data flow? And so if the community is going to lead community-led innovations and changes, how does that information flow to them?
Absolutely.
Yeah, I think it's interesting. It's a bit of a public health ethics issue. And the reason I say that is because if you took the data from Walgreens and CVS and you put it together, you would know at least 80% of the medications in the United States. And you would know which communities have more lisinopril, which communities have more of whatever medication you want to look at, which tells you that probably that area also has more patients with that, right? Well, which could be used for good, could be used for some positive things, but obviously can also not be used as well. So I think it's a really interesting issue. I think there's data sets out there that could begin to overlap, that could, have some really positive benefits, but doing it in a way that maintains the ethics and the security would be an interesting exploration.
A lot to think about. So thank you so much. And I think.
Thank you. I walked away with really, going to scale with real-time data, right? So we have individuals who are actively doing it. And yes, we need to make sense of the data for them. But as you now think of scaling it, the importance, whether you're using value chain or whether you're using multi-stakeholder engagement or healthcare system, it just shows also for all of the startups that might be here, you've got to take a systems lens to this as you think of the diffusion of your innovation, right? But at the end of the day, I heard all of you talk about trust and how you message it and what's the so what of the data and what does that mean for me, and it's still at the end of the day a human element and level. And so welcome back everyone for our final closeout fireside chat. I am most honored to have joining with me from Tokyo, Dr. Mintu Turakia, who is an internationally renowned leader in cardiovascular as a cardiologist and electrophysiologist, but also as a digital health and AI pioneer in terms of transforming cardiovascular care with wearables and those technologies. So we're fortunate that you're here with us from Tokyo and willing to continue in the conversation. Dr. Turakia is a Chief Medical and Scientific Officer and also Executive Vice President of Advanced Technologies at iRhythm Technologies, and he's also a founding director for a Center for Digital Health at Stanford University. And so I thought if I do my moderating job well, I've been trying to pick up some breadcrumbs along the way from our most excellent keynote, who's talking about Apple and doing this at scale, and panels thinking about health equity issues, AI transformation, and what do we make use of real-time use of the data for decision-making. So I'm going to pull out some themes from that. But I thought before we start, we had a chance to meet and we realized that people love when they hear stories of other pioneers and other hero journeys. And I thought I'd like to open it up and just see if you could share a little bit about your own entrepreneur journey that gets you to the part you are here today. We have startup folks, we have students on phone, and so it's really inspiring when you hear how people have made their journey and pathways to be the leader that you are today. So I'll give you a few minutes to brag.
No, well, so Elaine, it's great to be here. Thanks so much for the kind introduction. I am sorry, I think it's like 5 a.m. here, but I am sorry I can't be there in person. I really wanted to, and it just didn't work out. So thrilled we're able to do this virtually, and I can see the audience here as well, and I know you have folks who've joined online too. So great to be here. It's really an honor. I think that the sort of topics you're taking on are terrific, and in even looking at the profile of the audience and where they're from and what they're doing, what is clear and thematic, including my story, is you sort of jump different points along the way, as you very much have in your career. And so for me, it started to date myself in the early 1990s when I was an undergrad. And if you were an undergrad in the Bay Area, there weren't too many things you did. One of the things you did was go into computer science back then, and your hero was either Steve Jobs or Bill Gates, depending on your preferences. And I started there, and I very quickly got interested in combining technology with healthcare. My grandfather was a cardiac surgeon in India, but he sort of put down his scalpel and decided to go back to the village he came from in Western India and just pretty much be a village family doctor, which is remarkable if you think of a country like India and if you think of how unscalable a cardiac surgeon becoming a village doctor is. But when I saw him practice, he didn't have very much. He had his brain, he had a stethoscope, a reflex hammer, and a really old 12-lead ECG machine. And at that point, again, 1990s, the interest in technology got very stimulating for me. And I started working on wearable technologies and tools that I thought could help scale healthcare in places like India. That was really the driving force. Ultimately, it made more sense, and I really loved medicine and patient care, and went down the journey of medical school, internal medicine, cardiology. And from there, as cardiology is a very sort of data-heavy, clinical trial and epidemiology-heavy field, there was sort of a natural marriage in my interest in data science and really biostatistics. I think we call it data science now, and then developing tools and technologies. And so that led me to complete all my clinical training in cardiology and EP, and have a faculty position at Stanford and chief of EP at the VA. And what was very exciting there is we started to do some things that now we sort of take for granted, but at that time, no one was doing that. And one of those things was taking implantable device data, so pacemakers, defibrillators, things that we commonly use in cardiology, and linking that data to health data that had just started going electronic with EHR, and linking that to claims, which had been around a long time, but very few people were linking all three. And so that got into a lot of epidemiology and health services research, because you had these continuous signals that you can look at around, for example, around atrial fibrillation and atrial fibrillation burden, and so many sort of interesting things in arrhythmias and cardiology. Once you do that, you start thinking about, well, what can I build to really have an impact, and how do we test that? And that started the Center for Digital Health. And that's where we started doing a lot of trials, including the Apple Heart Study, including many others, on not just showing that a technology can engage patients, it's a pretty soft endpoint, but really looking at clinical outcomes. And so ultimately, all of that continues, but now the opportunity to do that from a company standpoint and scale, and we can talk more about that, design AI, design wearables, but then rigorously test them and make sure that they are sort of fit for purpose with issues of access, digital literacy, and health equity is a really fun challenge, and that's what I do now.
Yeah. What I hear from you is what I hear from a lot that go into fields of health. They're often inspired by something personal in their lives or an observation in a community in which they live, and how that then becomes a touchstone or through line throughout life. I'm also hearing you're like entrepreneurs, an open curiosity to see new tools and innovation. And I think that's the beginner's mindset as well. So even though you're an expert in many different ways, I still hear that voice of a beginner's mindset and being curious about new things emerging and new ways of putting things together and building and that. So it's inspiring that way. Maybe a couple of questions to set the stage. You know, how would you describe, from your lens, your vantage point, the current state of science and technology? Let's focus on the U.S. maybe, particularly as it relates to digital health and cardiovascular. We've heard great examples of what's possible. We've also had some speakers talk about barriers of access, et cetera. Where are you seeing the current landscape right now?
That's a great question, and it's rapidly moving. So if you look at the kind of foundational disciplines or medical specialties where digital health really took off, it's two places. One is diabetes, with the advent of continuous glucose monitoring especially, and that is a very engaged community of patients, a lot of type 1 diabetics, body hackers, who are managing their own insulin algorithms and using sort of AI on themselves. And it's a very sort of citizen science community. Whereas more on the kind of academic enterprise side, it would be cardiology as the other specialty. And where we see this in cardiology is, you know, what's so great about cardiology from an epidemiological standpoint is there's a lot of patients, the prevalence of disease is high, and the outcomes are fairly easy to measure, and those outcomes are valid and accepted, right? That's very different, for example, than in mental health or in other specialties where, you know, you just can't measure things, or death, which is easy to measure, isn't the outcome of interest. So it really came from the implantable side, where remote monitoring of implantable devices, where the data transmits from home to a server to a doctor, and for which there is stable reimbursement and it's mature, has been around since the 1990s, since almost the time that I was goofing off making wearables at Berkeley as an undergrad. It then became non-invasive as the technologies improved. And then we went through this rapid period, arguably we're still in it, where the technology development and even deployment outpaced our ability to rigorously measure and test their efficacy and safety and adopt them. That was one thing. And so in terms of adoption, we saw a lot of movement on the wellness side where there's a lot, right? Smartwatches, consumer devices, things people can buy for themselves, at a big box store or on an Amazon. We still have a lot of work to do on integrating this with clinical evidence. Where we have seen a ton of strides is in regulated medical devices, and particularly AI with multi-sensors. So for example, at iRhythm, we service almost 3 million patients with ambulatory ECG monitors from a patch. And that patch started with an unmet need where people were using devices called Holters that had wires and could only record signal for 24 to 48 hours, and you couldn't wear it in the shower. And the technology improved and it all got better, and now you have uninterrupted signals for 14 days. And that really is the true diagnostic, where if an Apple Watch or a smartwatch says something might be wrong, you need the definitive testing. And that will continue, and it does continue as we think of progressive miniaturization and adding on sensors in the medical stack. Where the gaps are how clinicians should actually use these beyond very specific use cases. Who should that be? Where does the burden of information and the obligation to act on it lie from a sort of medical liability standpoint? Yeah. Those discussions continue, but the uptake continues to rise, and there are ways that disparities are being addressed too.
Yeah, I think just listening to you in sort of the long course, it reminds us, while we may say, gee, this all seems like it's exploded in the last few years, the reality is all of the underlying fundamental experience of using wearable devices that may have been medical, that experience and learning, assimilation into the clinical care, it's all like the precursors, if you will, that is enabling the adoption that we're seeing today. My father worked many years ago at Bell Labs. And so a lot of the technology that was envisioned by scientists back in the 50s and 60s, just being able to have this kind of digital video conference conversation was imagined by innovators, but it took a while to get infrastructures and behaviors and familiarity and cost and that. And so I think that's one lesson learned. Many innovators have ideas that might be ahead of their time, so do not get discouraged. Look for ways in which you can be looking at the precursor solution that can maybe move your way to where it is. I mean, that's the story of Steve Jobs, right? And Apple and that as well.
I think in healthcare, one quick thing there is what really accelerated this. I mean, I think enough time has gone back now that we can look back at the pandemic and say, COVID accelerated digital adoption, right? So if you look at health systems, they had a weaker, health systems they are known to have sort of legendary slowness in IT. Like that's the thing, right? I mean, even getting tools in a health system takes forever. What drove urgency was the pandemic, a shutdown, the need to give patients care, people getting sick at home, and the fact that hospitals aren't going to have money unless they can see patients, and Medicare says, okay, you can see them remotely now because we're in a pandemic. So what was very remarkable there is within 2 to 3 weeks, every health system was able to operationalize video visits, right? That was the urgency required, and it's those external pressures that we think are, yes, they're societally, a pandemic is a horrible thing, but it was the true accelerant of digital medicine.
Right, and suddenly people had to learn how to use Zoom and technologies that are the patient public population that is also needed to be enabled and be comfortable with telehealth or transfer of information. Yeah. I mean, even the adoption of electronic health records was facilitated by the Great Recession, and it was an opportunity for investment, and that was the catalyst that got even adoption of electronic systems and health. So as I was listening to our different panels, and as I think about data, a common theme kind of read through this idea that it's data converted into knowledge, but knowledge for a purpose or action. And so I thought it might be interesting to sort of hit on a few of these things that speak to that, right? So we heard from Dr. Kumar from Apple, and it resonated with some of the discussions you and I had in thinking about design features for these kind of wearable. How do I know when to take action? This gets to what we are familiar with as sensitivity, specificity, positive predictive value, things that public health screening is used to thinking about, but now is being applied in this kind of setting. I'm just wondering, as you've worked on different projects, how do you go about the problem of knowing where to level set your target product profile as it relates to your sensitivity or your risk of false negatives or specificity or your risk of a false positive? How do you think about that, and what would you advise startups or innovators who are trying to figure out what's good enough?
Yeah, it's a really good question. There's a lot there. So I think, I did work with Apple very closely as one of the two co-PIs of the Apple Heart Study. So there's, as you think of a target product profile and what you need, what are the minimum requirements, it comes down to, number one, make sure you're not forgetting the unmet clinical need, and make sure that you have a very compelling need statement that includes what you're trying to address. So a better way to do X in Y population for Z outcome. So you need all three, the X, Y, and the Z. Like, what are you trying to do, in whom, and for what outcome that you can actually measure? That is going to determine everything. The other part of it is, AI is not it's a thing, but it's really not. It is no different than any statistical model, any risk model, any decision tool, or any laboratory biomarker. And they all have their positive and negative predictive values. Now, in epidemiology and in public health, and in most academic journals, we really hang on to ROC curves or C statistics and sensitivity or 1 minus specificity at the different cut points. And we use that to assess discrimination at a population standpoint. And that's fine if you want to deploy a specific thing in a population and you want to see what it does. But that doesn't help the patient in front of you. The patient in front of you is, what do I do with the result of this test? Does it need additional testing or not? So on the regulatory side, you have to clarify the intended use. The intended use of an ECG or an ambulatory cardiac monitor, such as iRhythm, is for ultimately for a doctor to diagnose and treat and make the diagnosis from AI-guided interpretation, but ultimately the physician is making the diagnosis.
Yeah. So we caught you at the end of a very nice discussion. You were getting to the point about it's not just population-based sensitivity, specificity, but what does this mean for an individual person decision, whether it's a patient or a public?
Exactly. So it's the positive predictive value, the negative predictive value, but it's also before that the intended use. Is this a medical grade diagnostic, such as the patches we make at iRhythm, which is intended for a physician to directly diagnose and treat? If you see atrial fibrillation on our patch, you can say that that's AFib, it's a diagnosis, doctor can use that and treat. When you have a smartwatch that just measures a regular pulse and it's consistent with AFib, and it might be AFib, the intended use is what's called a pre-diagnostic to get confirmation. So if you have a lot of pre-diagnostics, and there's many in the AI world, which are not gold standard, but suggest disease or a condition, you need to make sure that the intended use is ruling in or rule out. If it's ruling in, want to make sure that the positive predictive value to PPV is reasonable so that you are not testing so many people to generate a result. Typically, the FDA would like PPVs, at least in cardiovascular, above 30 or 40%. For some rare conditions, 10% is okay because they're life-threatening and we have new therapies. It could also be framed for negative predictive value. The second part is the user experience and design. Am I making this thing for the users that will trust it? is it working? And so we have a very large user experience and design team at iRhythm, which is unique in medical devices. And we measure a lot of things. We look at our compliance. We look at the wear time. We look to see if patients are actually wearing this, returning it on target. We have nudges in the form of text messaging. We have a companion app that will also have a native Spanish language soon, and we'll continue to add languages. And from a health services research standpoint, again, going back to fundamentals of public health, you can start seeing very quickly if these tools are effective and if they're having the right intended use. We made sure that if a patient gets the patch mailed, that the wear time, the signal quality, the adherence and compliance is no different than if it's done in person by a qualified technician. And we have tons of data and multiple trials to demonstrate that. Then you can scale, and the disparity improvement is, well, if this is already covered by insurance, I've now just saved a busy mom who's a working mother of 3, from spending half a day driving in, paying for parking at a large hospital or a clinic, waiting, getting this device, going home. Now it comes to her. She puts it on. She may use the app. She's told when to put it on, when to return it. It goes back by mail. The result goes to her doctor, and they can, even have a phone call if needed. And so I think the end-to-end of AI is exactly that in the way you articulated it.
Right. So it's more than just doing the math of the particular model and really thinking in the context of how this is going to be used for what kind of decisions in that whole health decisional tree, if you will, like you're saying.
Exactly.
You mentioned insurance. We had some discussion around insurance or access or billable, because it's more than just the device. It also means in some cases you're going to have clinical care and assistance, and is that billable or not? What have you learned from the insurer-payer side that might be some generalizable pearls of wisdom that people should have top of mind as they're thinking about that part of the value chain?
So there are many ways for value creation and revenue generation that aligns with outcomes. But what you have to understand is the usual problem is incentive alignment. So what group are you going after? And so often what happens is people are seeking medical clearance, regulatory clearance for a product, and it becomes an uphill climb. And they're like, you know what, I'm going to sell it as a wellness product, and I'm going to go over the counter, and I'm going to do this, that, and the other thing. And then ultimately, I'll become a medical device. Very few people make it in that way. The other way is to get a regulated medical product. If you have a regulated medical device, then either it's add-on reimbursement, generating new reimbursement, which is typically a Medicare CPT procedural code, sometimes an add-on code, sometimes a modifier code to an existing product. So, for example, let's say a 12-lead ECG is reimbursed. Now you have new AI that can detect if there's heart failure present, if the heart is not pumping well, or the ejection fraction is low. You can get breakthrough designation, you can get an add-on code. Just because you have an add-on code doesn't mean people are going to pay for it. And so now you have to create an evidentiary framework to show that there is return on investment. That's a hard uphill climb, but that's the right path. That's what we've done at iRhythm to create our own codes many years ago. The other way is to look at value-based care. And with value-based care, there are 2 incentives. One is to make sure that you have identified all the comorbidities a patient has, because how you are paid as an MA provider is based on the comorbidity risk burden that the patient has. The second is, if you're armed with that data, in theory, you should be able to act on it to lower cost and minimize hospitalization. And the incentive is shared savings or your own savings because you're given a single capitated payment. In value-based care, AI is being used, and that's where a lot of the implementation studies are, but it just depends on the product and the problem. A lot of AI helping doctors, ambient scribes, EHR layers to do chart reviews more easily aren't always regulated products, and those are being sold to the health system because they're enhancing the efficiency of care.
Yeah.
And so you really have to think through what you're trying to solve for to then determine the value.
Yeah, really have a good understanding of what is the current clinical workflow practice, how are things billed or not, and making sure as part of the customer discovery you're doing is talking to the people who pay the number flows for the health
Well,
unit, right? And understanding
yeah.
their lens of it.
The biggest mismatch you see with early stage companies is that there's misalignment between the outcome they're measuring and the person who would be paying for it. So let's say you have AI that makes chart review much easier. You don't have to go through mountains of epic data, and you have basically generative AI and other tools that can help summarize the chart record. And you can ask it like, hey, is this patient's heart failure getting worse? Can you help me draft a prior authorization letter? Whatever. Can you find this person who meets these criteria for a clinical trial for recruitment? I mean, there's a lot of different use cases. But the person paying for that is likely not the user who's benefiting from any of those. It's hospital IT, it's the health system. And so ultimately, they are looking to see what the return on investment is. Is it healthcare efficiency? Is it my doctors are happier? Is it there's less burden? Is it they can see more patients? Is it, I'm coding better, my medical loss ratio is improved? So you just have to align the incentive with the person writing the check. And that is, I think, the biggest mistake we see.
Yeah. You have to think of all of the different variables, not just the clinical or that. So one thing, when Dr. Kumar was talking about Apple, they mentioned that they put all of their validation data, et cetera. You can get it online. It's accessible. We've had a lot of conversation of how do we make sure information is valid, trusted, and credible. So one of the questions I'll weave in that we got in here is, your thoughts on what evidence standards you believe are still missing for regulated cardiac wearables so that they are fully trusted in the clinical decision-making and by patients.
Yeah, so it goes always back to the intended use of the device. If you have like heart rate on a watch is generally not a medically cleared software device. You would obviously want to show that your heart rate algorithm measures what it's supposed to. It works across skin tones, X, Y, and Z. And that I think to Rajiv's point at Apple, Apple as a company has been very good at showing all of their data and being quite transparent about the rigor that they use. And I don't think the industry was that transparent, even for unregulated products, until the FDA called for greater transparency for regulated products. So it sort of cascaded down, and it's a great thing. The AI requirements that the FDA has and the guidance they put out is very transparent. They tell you what you need to do, and it is super rigorous. It works really well. Where I think there's a little bit of disagreement in the field and needs some consensus is what is the clinical trial outcome of interest? So let's say you have an AI algorithm that does a really good job at predicting risk of stroke once you have atrial fibrillation. And you want to deploy this. You have some people saying, show that it works. Okay, well, I can show the validation cohorts. They can be separate. I can look at my calibration plots. I can do all this stuff. And I think this, just as an aside to some of the students and public health graduate students here, I think understanding rigorous data science and biostatistics is a foundational skill that is super valuable in terms of a career and anything you do, and we can talk about that more. But as you get there, it's very rigorous. But then some people say, well, show me a clinical trial that it improves outcomes. And that's where I think it's a little more controversial, because the current precedence is no clinical trial. Somebody published is a risk score on low quality claims data. It gets into a nice journal, it goes into a guideline, and all of a sudden people are using it. But now you're automating a tool that has rigorous validation. It's clearly superior to that risk score, yet you want to see clinical trials. So once we clarify the intended use, that it's helped to guide the clinician, and it's not autonomously telling you a patient to take anticoagulation or not, it should be okay. But this is where people get a little hung up. The other area that I think creates confusion is the efficacy of these diagnostics out in the wild. And often it's referred to as screening. So I don't believe that wearing a smartwatch that has an algorithm to passively look for sleep apnea or AFib is screening in the same way that the WHO kind of Jungner-Wilson criteria refer to screening that were created decades ago. This is not a healthcare population intervention. This is something that a user is electing to turn on in their own life, and it may have a result that requires clinical action. So I don't think you need a clinical trial to show that it improves stroke and mortality to turn it on, as long as you can show that it's safe.
Right.
When you get into medical grade diagnostics, we see the same thing with undiagnosed AFib. The US Preventative Services Task Force has said, show me that looking for AFib improves outcomes. But we already know that if you have AFib, you're at risk of stroke, and there's life-saving therapies. We know that if you have AFib and it's untreated, your risk of stroke, heart failure, and other things goes way up. And we have randomized trials that suggest that treating patients with documented AFib actually improves quality of life, heart failure, cardiovascular hospitalization, and a whole bunch of other things. So tying the diagnostic back to the therapy for a trial, when you already know the therapy works, is a really confusing area. We don't have randomized trials to show that having a blood pressure cuff at home saves lives. We just offer it. And so there's a lot of confusion and conflation in the field of when you should have an outcomes trial and when you don't need one for diagnostics.
Yeah. You know, in some ways it's different, but you know, it's kind of making me think we have like supplements, right? Like we know vitamin D is good. It's been established in all of these clinical ways. Does some new way of delivering it need all of this, you know, to go back and repeat the same thing, or fluoridated toothpaste or what have you? We're kind of in a similar kind of analogy of from a regulated products, that's monographs and other ways of thinking about it, as opposed that they build on the evidence as opposed to you have to repeat the evidence generation each time.
And a clinical, and just very quickly there, a clinical trial is designed to test a strategy of care, whether it's a diagnostic or treatment. So yes, we should do a clinical trial if we want to deploy systematic screening. So if you turn 65 and your welcome to Medicare kit needs to include a colonoscopy, this, that, and the other thing, yeah, we probably need some trials with some outcomes. But you don't need trials on the consumer side. You need to show safety, and you need to show that the data works, and you need to do it responsibly, right?
Yeah.
So one of the areas is, if you're going to deploy an algorithm on a consumer smartwatch, which is not something we do, how many people are ignoring that alert? And are they then getting care? And if they were ignoring it, then you might have a problem in the design of it, right? Or the chain into healthcare.
Yeah.
And those are gaps that I think are worth addressing.
And that's why I think it's so important that people think of it also the intended outcome, but also the unintended outcome. And what's the consequence of the unintended? And how are we also assessing the things we don't want to happen to see how often that is happening? We've had a lot of interest in some of the questions coming in around the continuous monitoring today. We had an earlier session talking about thinking about it in real time, but also use of AI, and that do we have too much data streaming in too much? So part of the panel discussion was just from the practitioner, the clinician side. You know, it's a lot of streaming information that might be coming in from a patient. You know, what's enough? On the other hand, in certain cases, like you mentioned with the continuous glucose monitoring and how that relates to insulin delivery, that is like ideal, right? So how are people thinking about this in terms of continuous monitoring in cardiovascular health, and thinking about when is enough, and to really get it more broadly, you know, what's holding us back for broader adoption of these things then?
Yeah, there's a lot there. I think, so in the ECG monitoring world, our products do uninterrupted continuous monitoring for up to 2 weeks, and then you can repeat those for up to 30 days. And we have shown time and time again with trials, observational data, claims analysis, you name it, that strategy works for those 14 days, and that data is informative, it's predictive of outcomes, and it's actionable. And it's typically to identify discrete periods where patients have symptoms. We also know that 1 or 2 days is not enough and all that. Then the question people ask is, well, why don't you just monitor them forever? And the problem there is you don't really know what the threshold is for treatment. That's one. If you had a continuous recording, there are devices that can do that at some level with called insertable cardiac monitors. They're technically not live streaming continuous devices. They record snapshots that the device AI thinks are important. Then now those have been externalized, so they're non-invasive on the wrist. And you also have sort of, a lot of consumer watches basically giving patients check engine lights if they see something wrong, and then that needs a workup. So I think continuous monitoring and the way we've talked about this for remote monitoring, even in a New England Journal review we put together a year ago, is that it makes sense for discrete time-limited periods where high-intensity monitoring is necessary. So if you were admitted with heart failure, you're going home, there's a high risk that you may detune and get readmitted or get sick quickly. There's a lot of reasons for that. More intensive monitoring may make sense. But that's time limited, and at some point you get discharged, so to speak, from that intensive monitoring. For a lot of the other low-level background monitoring, I don't know if we know what to do with continuous measures, because the only way to see a pattern is to look at 6 months of data, for example, right? So did things happen? Did your exercise capacity start to diminish? This is something a lot of the smartwatches do over time. But you need trends. And the trends, okay, so you get more sampling points day to day, but you may not need those every day. And so then the question is, what is the optimal frequency for what? So on the wellness side, I think people are left to self-manage it. On the acute care, post-discharge, there's a lot of opportunity in having vital sign monitoring, complex monitoring, and those are things we do.
Yeah.
And then the periodic checkup monitoring is when diagnostics now are disintermediated from the doctor. You get them at home. So if you have a clinical suspicion of sleep apnea, you can get a home sleep test. If you can get our product for arrhythmia concerns, et cetera. That will continue, likely on an episodic basis, often driven by risk and symptoms. But I don't think we're likely going to be in a continuous monitoring situation anytime soon where you've just brought an ICU into your own house when you're perfectly healthy. I don't think
Yeah.
I don't think there's value there.
Right, so really a bifurcation. I mean, just what's really clinically minimally necessary given the patient care situation or discharge, and maybe it can come back episodically, like you said, but that's not necessarily turn on I love the check engine light analogy, because I don't know how many online or here, but mine comes on all the time when the tire is low and it's cold outside. And so after a while, you also become tuned out and desensitized to those kind of check engine, and that's also a human phenomenon as well that you have to factor in. We had some discussion around this idea that, these devices it kind of plays on this, can be used for an acute or short term, but also the longitudinal trajectory. How do you think people are going to be going about trying to study a trajectory, kind of? Are you seeing like very large cohort studies, forming up in which in a classic observational real-world data way? Are people starting to investigate it in a systematic way, I guess?
So, I mean, what is going to be the sort of Olmsted County 2.0, Framingham 2.0, et cetera? There are cohorts doing that. Google, the Verily baseline study with Stanford was attempting to do that. I don't know their most recent status. Honestly, I think the best one globally is the UK Biobank. And they're doing really interesting stuff. They have great trialists and epidemiologists involved. The National Health Service and their research institute has spent a lot of money. They measure a lot of things. And what's interesting is those things are not given back to the patient or the clinician. So you are seeing the natural history arm of a lot there. So we're going to continue to learn there. I don't think there's any single company looking to systematize all that information. And again, what we're starting to see is if people cannot show clinical evidence, they're going on these wellness pathways. So, you can go in and just get a cardiac CT scan, even if you don't need one, or a full body MRI if you're just kind of, quote, worried about yourself. I don't know where the data will go to show the utility. A lot of the marketing there is with anecdotes. So this person had this and had it not been found. Anecdotes are great, but maybe it would have been found even without paying for an elective full body MRI. And maybe that difference in lead time bias wasn't going to affect mortality, right? So there's a famous study from a few decades ago that showed that Marin County, which is a nice county kind of north of San Francisco over the Golden Gate Bridge, had the highest rate of breast cancer. And everyone started freaking out that there was something in the water in Marin County. Well, it was a community that had very good access to care and was getting mammograms. And the mammogram technologies were also improving, so the resolution was better. So you had more people getting screened, and then you had greater lead time bias because the detection at an earlier stage improved. That's good, but it doesn't mean that Marin County has something in the water that's causing breast cancer, right?
Yeah.
So this is where you have to be very, very careful. And
Right.
and again, as the dean of the school there, like it goes back to public health and epidemiology 101.
Right. And that's why I think teams of people are needed to look at these, the clinician, the data scientist, but also, thinking about the healthcare chain. I think I'll just give also a shout out that outside the US, there are countries that have from birth to death registries, right? And or, organized health systems such that they can be doing these very large longitudinal population-based studies. And so we need to keep our eye on what's coming out of countries like Denmark or Sweden, or as you said, UK, because that's sometimes where it may be different setting than what we have here in the US, but some of the ability to do that kind of longitudinal work exists. Okay.
I think one area, one gap, one opportunity, if people are in there in the space, has nothing to do with cardiology, and I'm not an expert, but it's measurement of mental health as at the population level, right? Like we don't do that. We have estimates of hypertension, this, that, and the other thing. Most cohort studies, to my knowledge, are not focused on kind of mental health instruments to look at anxiety, depression, other scales. Neurodiversity, looking at kind of neurodevelopmental, neuroatypical features. There's a huge opportunity there because we don't really have a good handle on what's happening in the country. You start getting things like autism's on the rise, ADHD is on the rise. Well, yes, the observed prevalence is it the Marin County thing? Is it lead time bias? Or are there true changes in the underlying exposure risks that are changing things? It's a huge opportunity and we don't do it well.
Right. So entrepreneurs need to kind of be looking at what's going on in the broader trends of the understanding of the underlying disease in which they're trying to disrupt how it's cared for, right? We're coming to the near end of our time, so I have a couple remaining questions. One is we talked about, as a Jesuit university, we look through science through a humanistic lens, and you've been on the ground implementing these kinds of wearable digital device and innovation. Taking the human lens of the very use and adoption of data is a human process that's complex. What have you learned about what's, the minimum ingredients that are needed for successful implementation?
I think it's a really great question, and it's just great to see how sort of the university is grounded in those principles. We just have a lot of tools and hammers looking for solutions and hammers looking for nails, and the real question is, well, how do you build this? So it goes back to the clinical need, and you can say, okay, I've checked that box, but then it goes to this sort of real patient factors, human factors. Is it solving the problem in the intended population? Do patients trust it? Are people using it? Is it, qualitatively seem right, for lack of a scientific way of framing that, right? So if you create a great technology and you can't get it approved and it's only being used by sort of really wealthy people focused on longevity, is that part of your mission or not, right? So it's good to ask those questions. And if you're thinking of scale, you're not just going for Uber Black. You're going for Uber X. You're going for something that is accessible to the masses. And around in California, we now have autonomous vehicles everywhere with Waymo. That you have to create that user experience for the entire population. So I think looking at trust and equity and access, we're very committed at iRhythm to making sure patients can get our products through Medicaid, through other solutions, that they trust them when a box shows up at their door. There isn't scrutiny and skepticism. And that all goes into design, use, regulatory, human factors, patient satisfaction, and just kind of doing good.
Yeah. So, what promising trends do you see on the horizon that might accelerate some of these ideas? Considering the companies who are developing wearable or cardiovascular technologies in particular.
Yeah, so I think, the opportunity for the sort of people attending the great forum at Matter you're doing is sort of, where do I fit in this whole thing? Where do we go? The opportunity is in implementation and evidence. There's a lot of technology creation you can do. We're seeing a lot with large language models and generative AI. We're seeing a lot of bots and agents. But fundamentally, doctors don't go away. They may be doing different things or better things, but you're going to need physicians. You're going to need great people with backgrounds in data science and biostatistics who can think rationally and intersect clinical, regulatory, science, public health policy, reimbursement. That is a superpower, whether you're in an academic environment running a multidisciplinary lab, or you're going to start your own company or go into another corporate environment. You just need to, the multidisciplinary aspect is huge. So I don't think there's any one thing. I think there's a lot of slow process along the way. But more likely than not, the consumer side of things will continue. The medical grade diagnostics will continue. We'll start getting more rational evidence on how and when they should be used more globally. But overall, the adoption will rise because access to cellular data and internet, it has a low barrier now worldwide. And so what I'm still hopeful for is you can kind of scale things in the way that a cardiac surgeon in a village in India is not scalable. Maybe these tools do help augment the care. And one clinician can now really be able to manage 5-fold, 10-fold more patients because of the tools, not because they're working harder and burning out. And then they can do it more effectively, right? So I think that's the goal for all of us.
So putting on your leader hat then, what I'm hearing you say is to be effective, we've got to be comfortable working in multidisciplinary teams, or being able to work with the commercialization side, the regulatory side of folks, et cetera. That's often not a skill that's taught in class in a book. So in the real world life textbook that you've experienced, what have you learned are some key ingredients for success in that regard? Either identifying team members you're bringing on or maintaining, this whole idea of you form, storm, norm, perform, right? You're constantly doing that. What have you learned it's really essential?
I think some of the advice I got, so Peter Libby, who was the chief of cardiology at Brigham and Women's when I was a resident, gave really good advice. And this is sort of 25 years ago. He said, as you think of your career in whatever you do, investigation, clinical care, whatever, don't focus on the tool, focus on the clinical question. And that still, in my view, is the right way. So don't just be the AI person. I mean, you can if you want to be an engineer only and you are interested across different modalities and you want to build, but even that engineer who understands clinical care and other things will be able to do it better. I think when you are focused on a question, so in my world, it started with sort of health services, outcomes, research, risk prediction, and the effect of clinical interventions for atrial fibrillation. How much AFib is too much AFib? Is there overuse? Is there underuse? What is the variation in care? And that led to sort of epi, outcomes, health services, and therapeutic questions. And whether it's answered with a cost effectiveness analysis or a trial or an implementation stepped wedge design, those are all tools, but you focus on the question. And that's the same if you're in an industry environment. Like you can focus on a thing that you're looking to solve. And you may solve that in many non-obvious ways as long as you're focused on the question.
Yeah.
If you're focused on the tool and the tool isn't the right fit, you're going to be biased in trying to fit the tool and that hammer looking for a nail. And sometimes you will get lucky and that will work.
Yeah.
But my advice is like pick a problem that you care about deeply and just stay with it and try to be multidisciplinary. Knowledge is no longer contained. You don't need a degree in 10 things anymore. You can find the knowledge and find people who can help you. So stick to the problem, be very multidisciplinary, have kind of a global view on things, and I think you can have a lot of impact.
Right. So then if you follow your nose with the problem, then that will organically lead to other sub-questions and what-ifs to validate what you're doing. And then that will lead to, I'm going to need expertise in area A, B, and C now to be part of my journey together, because I don't necessarily have the skill to answer that particular thing. So it sounds like, grow the team by following the problem you're trying to solve, and then assemble the expertise that's needed to get you to the next step. Am I summarizing?
Yeah.
Close, yeah.
Yeah, because from an academic, that is the biggest accelerant if you're going to stay in academics. You start building multidisciplinary teams, and all of a sudden now your own research program is multidisciplinary.
Right.
So you're the person who can speak across different cross-cutting ways. The same is true if you're running a product in a tech company or you're building your own program.
Right.
It's key to know those things and have a wide aperture.
Yeah. Well, I just want to thank you. We'll give a clap from the room, so maybe you can hear us.
Thank you.
I think it's a wonderful capping for the day because, we hear people that are at different stages, and I think your experience, across the last couple of decades as the field has been evolving, and the evidence generation is really grounding as to, okay, what steps are needed to keep us moving forward and continuing to innovate in that area. So I'm just so grateful that you joined us, despite it being, I guess, tomorrow morning. You're with us today.
Well, I think you probably saw the sunrise come behind me. I can see the window, and
well, I wish you a very good day. Thank you very much.
Thank you. Great to be here, Elaine, and really congrats to this great program.
Yeah, thank you so much.